Broadcast now. We're broadcasting live.
Can you see it?
You're great.
Yeah. Okay.
Welcome everyone to the Texas webinar. Super excited to have everyone here this afternoon. So while everyone's coming on, we're just going to give everybody a few minutes to come on. Sorry we're a little bit late, so a few little technical issues, but it's definitely going to be a great webinar. So Rick, I really want to thank you and Keith for putting this on. I think it's great. I think that Texas has some different little things out there that it's kind of nice to know about. So again, I really want to thank everyone for coming on, and I always have to open it up and give you a little rundown about how the CEs work. So number one, when you signed up for this program, you will get CEs. However, please make sure that you use your legal name when you signed up. And what I mean by that is a name that's on your license, because when you receive your CE certificate from us, it will have whatever name you registered in. So if your real name is William and you registered in Bill, they won't take it for your CE for your license when you go to turn it in. So if you did that, no problem. Just hold on, I'll give you some information on how you can correct it. The other thing that's really important is please make sure that you log in on your own computer. If you log in on someone else's computer, we won't know that you're on. So please make sure if there's two of you that you're each logged in on your own computer. Everything is time stamped. So if you get off early, you will not be able to get the CE. So please make sure you stay on for the entire time. When we turn them into our CEs, we have to make sure we have records of that. And the other thing that's really important to know is that if you registered and you used your cell phone and you want to watch it on your cell phone, that is perfectly fine as long as you use the link button. However, if you're just listening to us on your cell phone and you still want CEs, you're going to have to do me a favor. You're going to have to send me in your name, your telephone number, and the course description that you're watching. And the reason that is because for some reason that doesn't register your name, and we want to make sure that we can put those two together to be able to give you the CE credits you deserve. So with that being said, if you have any problem with your name or you're calling on your phone, email me at practicecoaching@binco.com. Again, that's practicecoaching@binco.com with any of those questions or any of those or your phone numbers, and we'll make sure that we take care of you for your CEs. With that being said, I also want to let everyone know that there's a Q&A at the very bottom. We definitely want you to ask us questions as we're going through. So please, if you have a question for the speakers, use the Q&A and we will try to answer them live. However, if we don't get to all those questions, we will do a full sheet of all the questions and answers, and everyone that's on tonight will get a copy of the Q&A. So with that being said, I have the great honor of introducing our very first speaker, who I absolutely adore working with and has spent a lot of time doing a lot of research for our Binco customers. I can't say enough about Rick. I think he goes out of his way to make sure he knows everything and make sure he gets it right for the Binco family and for the Binco clients. So with that being said, I would love to introduce Rick Cohen, Managing Director for Binco Dental.
Thank you so much, Kay, and welcome to all of you that have joined this evening. Today's presentation I think you may find interesting. We're going to spend a lot of time on KN95s and N95s, which is, I know, very much a hot topic in Texas. First, I'm going to read through a disclaimer. And this goes for everyone from the Binco side. This is just a lawyer stuff, but the information we're about to share represents our impressions based on industry knowledge and not research of any governmental or health-based agency rules and regulations. In a fast-changing environment, we urge practitioners to check with other professional advisors, attorneys, accountants, regulators, etc., as you restart your practices. So that said, I want to talk to you about what our goals are for today. We're going to talk about face mask authenticity. It's a hot topic right now. I'm going to talk to you about the do's and don'ts and the ins and outs of that. We will spend a lot of time on the worldwide supply chain complexities, gloves, face masks, clothing, and all other PPE. We'll talk about my notes on the coming PPE price increases. Actually, they've already come. We'll talk about China. China is a very hot topic these days, and very political topic, especially when it comes to PPE. We'll talk about that. And finally, when and how does our PPE supply chain normalize? So before I get started, I just, you know, in a webinar about COVID, it's most important for us to really focus on what's most important, which is this is first and foremost a health crisis. And from all of us at Binco, from our family to yours, we hope that COVID hasn't affected you. And we all must remember that while this has had a terrible impact on our business, and it certainly has on ours, I'm sure it has on yours as well. You know, it's been affecting us financially, but first and foremost, what's most important is that we have health of our family and ourselves. And so from ours to you, our family to yours, we hope that you're staying safe. It is still dangerous out there, and I just wanted to start with that note. Secondly, the challenges that we're facing in dentistry are not small, but we're struggling right alongside with you. As I mentioned to you, our business has really taken some drastic hits. Sales for a while were down 80%. Yours were down 100. But we had no disaster plan ready for a minus 80% scenario. We're very much in the same boat with you. We don't succeed until you succeed first. And from a business perspective, we're doing everything we can to get dentistry back up and running in Texas and all over America. So please know that it hasn't been easy for us either. And when you begin succeeding in your business, that's when we'll begin to succeed again in ours. But it's been tough all around. Similarly, the challenges in PPE these days are also not small. They're quite significant, and I'll explain why that is. And in some cases, it's the best I can do is explain why. I don't have silver bullets. If you tuned in for that, I'm afraid we don't have them. We do have some good news, some not so good news, and mostly in the next 30 minutes, I think you'll have an understanding of what's really going on out there. So, let me, I will also say that part of what I do at Binco and what I've done for 10 years is product sourcing. I've spent a lot of time in China, made 40, 50 trips over the past 10 years. I've also traveled all over the US and the rest of the world, spending a lot of time in PPE factories. And so I really do understand the industry. And I'm going to share a lot of what I know with you today. Okay, so let's get started. First, we want to talk about face mask authenticity. When I first started doing these webinars, for a while, no one really cared that much about PPE. As of March, everyone cares. At the beginning, when I started, I first had to explain what an N95 and a KN95 was, because most of the dental community didn't even know. But I'm not going to go there now. We all know what it is today. And you also know what a KN95 is, and you know the difference between the two. What you may not know is that some very basic things, like, for example, if you see an N95 with ear loops, it's not an N95. So, and ear loops are not part of the N95 standard, but they're part of the KN95 standard. So you can see a KN95 with ear loops. In fact, most of them have ear loops, but you'll also see a KN95 with headbands. You may be wondering which is better. I don't think there'll be much disagreement that headbands are better than ear loops. If you've tried both, you see instantly that headbands, which go all the way around your head, really hold the fat mask to your face and really stop the air from seeping in unfiltered from the side, which is the whole point of N95s and KN95s. KN95s have a lot more leakage around the side if you wear them on your ears. They're quite good though. Their filtration rates are superb, very similar to an N95. In fact, 3M themselves have said that the KN95s are pretty much just as good as the N95s if you can get them on your face tightly. One tip, and I'm going to show you a photo very soon, is, well, you know what, I'll wait till the photo's coming in 3 minutes, but it'll show you a way to wear your KN95s in a more secure way, and plus take a lot of the strain off your ears. But what we're finding is that basically the German version of N95, the European version is called FPP2. You'll never see any of those because they all stayed in Europe. The Japanese have a version and the Koreans have a version. Generally, the Japanese ones have generally stayed in Japan. Koreans the same. The US ones are obviously the brands that we know, which are the 3M, Alpha Protec, and there's 2 or 3 or 4 other big ones. But in a lot of N95s have also been made in China, 5, 6, 7 factories. And KN95s, of course, all are made in China. And the problem with KN95s is that when they're good, they're good. When they're not good, there's a real problem. And the Wall Street Journal and New York Times both wrote articles 2 weeks ago where they tested a number of KN95s. And in some cases, the failure rate was substantial. For example, an N95, and KN95 is supposed to filter 95% of the tiny particles under a certain size. And in some of them, they've only tested at 15%. So that's why the government and the FDA have cracked down so much on the KN95s. The reason we have so many KN95s is because in China they make them, they make a lot of them. The problem is that it's so hard to verify the authenticity. We work literally around the clock at Binco, day and night, to try to get good KN95s. And what I'll tell you is it's been very, very hard. We've evaluated over 100 various versions of KN95s, and so far only found one that that passed all the certifications and that we can feel comfortable selling. So it's been very, very hard, it's really a crazy market. And I'm going to get more into that in a minute. The worldwide demand for masks in general is up 4 to 5x. The worldwide demand for N95s and KN95s is up, I don't know what the number is, but it's probably 20x. It's the best protection against coronavirus that we know of. And that's why we're seeing tremendous demand. Dentistry never used N95s or KN95s. We used them. We had them as a SKU. We hardly sold any. In fact, I bet you we sold for one N95 for every 10,000 flat ear loop masks. And in fact, many dentists that I talked to, well, I would say 30–40% of dentists that I talked to and staff didn't really know what an N95 was. They know now. So part of the problem in a time of a crisis is that when there's limited supply, which of course there is, you can't just wave a magic wand and create a factory that makes N95s or KN95s. But in a time of crisis, the factories generally, the good factories generally, see who was buying the product before the crisis, and then they reach out to those purchasers and they say, well, we'll make sure that whatever you bought before the crisis, we'll ensure your supply going forward. The problem with dentistry is that before this crisis, dentistry never bought N95s or KN95s. So those good factories like 3M or Alpha Protec, when we called them after the crisis and said, we need N95s to start dentistry and keep our dentists and staff safe, they said to us, we can't help you. We've got to take care of the customers that used to buy before COVID. They further went on, especially 3M, the largest N95 maker in the world, and they said, our hands are tied by FEMA, our hands are tied by the US government, and so we're busy navigating those problems. And so it's that reason as well that we can't put too many N95s in the dental community. So it is a real problem, and we're dealing with it. Government before March never cared about the mask business. They care about it now. In fact, we got a order from the, we're based in Pennsylvania. We got an order from the Pennsylvania governor's office that said, send us your inventory of all PPE. We've never got anything like that before, ever, in our 90-year history. New York government did the same thing. I'm not sure about Texas, but I know in New York and Pennsylvania, at least, the government has been very interested in our supply of PPE. We had to submit a full inventory of all of our PPE. 3 months ago, they didn't even know who we were. They didn't care. Now they care. So far they haven't seized any of it. And believe me, if they try, we will make very strong arguments that dentistry needs our supply of PPE. We need to get dentistry started. We need to keep our dentists safe, our staff safe, and we need to do it because dentistry is part of healthcare. And in fact, there's a lot of dental problems that can lead to very serious health issues that are worse than COVID. So we will make a case if it ever is seized. So far, they're not making overtures that they will, but they do have our inventory and they do care. I'm not going to spend any time on I'm going to take you into a flat ear loop factory in a minute, but I'm not going to spend too much time talking about flat ear loops. In Texas, you can't use them anymore, is my understanding, what I just read. The most aggressive state that I know of with regard to mask rulings, I haven't heard of any other state requiring KN95s or N95s. Texas is very strict in that regard, so I'm going to stop. I'm not going to talk about flat ear loops. Okay, so what I'm going to do is I'm going to take you into, well, I want to show you this slide really quick. This is from the CDC website. There's some bullet points on there that show you some easy ways to tell if a respirator is counterfeit. These are not the only ways, but they are keeping that list up to date if you're looking for easy ways to tell. It's not a complete list. There are good fakes coming out of China right now. Here's an N95 that we found with ear loops. As soon as you see an N95 with ear loops, you know it's counterfeit. Ear loops are not part of the N95 standard. I mentioned the Wall Street Journal article that shows that many of these KN95s are inauthentic and not real. A lot of liability is, there's lots of liability if you do sell inauthentic or counterfeit masks. Okay, and I wanted to go through some of the ways that we validate face masks at Binco. Specifically on the KN95 side, we have got an entire regulatory department that works literally day and night on this. One thing they do is verify the FDA registration. We found that many KN95 makers were registered with the FDA only since March of 2020. That's generally not a good sign. We identify fake certificates and documents. The fraudulent KN95s often come with documents, sometimes with official FDA logos on them, but the FDA doesn't issue certificates. So we know that they're not real. We find out if the factory is FDA registered for face masks. Sometimes they're registered for mattress covers or some other thing, but not face masks. So that's definitely a red flag that we look for. And then the piece of data that really separates the men from the boys and the girls from the women is the FDA device listing number. That's a secret number that the FDA gives a factory when they give it. And it's not published anywhere. So we ask the factory what their FDA device listing number is. And then we go to the FDA and we cross-reference to make sure it's authentic. 70% of the KN95 people we talk to, when we ask them that question, they go radio silent. And so it happens that the leader of our regulatory department happens to be on the call with us today. He's awesome. I've worked with him for years. His name is Jim. And if we get any really tough questions about regulatory, Jim may answer them later when we get to Q&A. But those are some of the things we do. It's not all the things we do, but we do keep our regulatory department quite busy. Okay. I just put this picture in because I thought it was kind of cute. But this is a KN95 sample that we got. And I love this at the bottom. It said, breathe freely and bring forest into home. And you have to know, someone in China must have asked, does anybody speak English here? And then probably someone raised their hand, and they helped design this box and put in this little piece of poetry, which is cute. And I like to put it in here because it's not what you would see on an American box. It does not indicate whether or not the mask is authentic or not authentic. It has nothing to do with it. But it's just a little piece of, I just kind of thought it was cute, so I put it in there. This actually turned out to be an inauthentic mask, but it could have been authentic. It just had some weird writing on the box. Okay, I'm gonna skip to gloves and get back to masks in a couple of minutes. I'm running a little bit late. Gloves are a very interesting product. Gloves are all made, 100% of them are made in Southeast Asia, in Malaysia, Thailand, and Singapore, and Indonesia. And you might think, when you think Malaysia, you're thinking Gilligan's Island maybe, you're thinking palm trees, you're thinking coconuts for lunch, and all that is true. But the factories are not like Gilligan's Island. And let me show you one right here. This is one of the newer factories in Malaysia. And if you can see that red arrow, that's pointing to a tractor trailer. That gives you an idea of what those factories look like. They're amazing, they're huge, they're highly automated, and they are really good at making large quantities of gloves for the entire world. This is the inside of a glove factory, fully automated, as you can see. This is in a different factory, but it may come as a surprise to you that the gloves are still stripped in most factories by hand, usually by Nepalese or Bangladeshi labor. Each glove is hand removed. And it also may come as a surprise to you that each glove is counted and flattened and put into a box by hand. If you look in the lower center of that picture, you'll see glove boxes that are empty, and the workers are putting those gloves in 100, 200, 300 at a time. Still very manual. So that comes as a surprise to a lot of people. I'm going to skip over gloves because we're short on time, but gloves I'm not very worried about for dentistry. We're going to get enough gloves. We always bought gloves. The factories are all taking care of us. They're giving us what we bought before. And I think we're going to be fine on gloves. So I'm going to skip through that one. But I hope that you thought it was interesting when I took you into that factory. Face masks. I told you all about face masks a couple of minutes ago. We talked about N95 and KN95 because that's what's most interesting to Texas right now. But I want to take you into a flat ear loop factory right now. And before I do, I just want to show you one picture really quick, because this is an invention, little hack, a little mask hack that the spouse of one of our associates took, and it's in case you have to wear a KN95 or even a flat ear loop with ear loops, and you want to take the strain off your ears and make for a tighter fit. If you got KN95, you don't need to put this knot in, but if you happen to be using a flat ear loop, maybe when you go to the grocery store or whatever, because you can't use them in your practice, we recommend that you get one of these headbands, nice tight fitting one, put in a button on each side. It takes the strain off your ears and it'll hold the mask a lot tighter to your face, so you'll get less leakage. We thought that was a great invention. Okay, I'm going to take you into a mask factory really quick. This is a flat ear loop factory. It's not a KN95 factory, but I just think it's interesting. Starts with the raw materials, of course. Would you be, many of you are probably surprised to see that the ear loops are mostly put on by hand. And I think the same is true with KN95s as well. And probably 70% of the Chinese factories, those ear loops are all put on by hand at very high speed by very skilled labor. Here's a whole workshop of people putting ear loops on masks in China. Now, it's not how they're made in the US. In the US, they're made by, the ear loops are put on by a machine. They wouldn't let me take any pictures of the US factories because of trade secrets, but in China, they didn't mind. Okay, more ear loops getting put on. And here is a cone mask factory where you have men putting the cone masks in boxes. Whenever you get anything from Amazon or anything from Binco or any dental supplier, and it's packed in a brown cardboard box, there are human beings that put it in that box, and you never think of that until you get to see it. And so I thought that was interesting. And then here are mask inspectors in a cone mask factory. And finally, again, we're in flat ear loops. Don't really apply to you, but this is one of the machines that make the flat ear loops. And here, if you can see my mouse, you can see the pleats being put in right there. It's kind of interesting. Okay. Now I'm going to skip on to the next topic, which is clothing. I'm going to take you into a disposable clothing factory right now. I think you'll be very surprised with what you'll see. First, as in every factory in China, US, Europe, anywhere, it always starts with raw materials. The raw materials often are not made in that finished goods factory. They're made by other factories. It's usually a chain of factories that finally go to a finished goods factory, which then gets put on a container ship, or in the US, a tractor trailer. But here's the raw materials. The main raw material in disposable clothing is a product called non-woven. Would you be surprised to know that all of the disposable clothing is made by hand, by sewers, people with sewing machines, very skilled labor. It starts with patterns, just like if you walked into a suit factory or a dress factory, they start with patterns. They cut from the cardboard patterns, and then they get to work. And in China, they're paid piecework. They work very long hours, and they're very skilled. And if my life depended upon it, and they helicoptered me into one of those factories, I wouldn't be able to do the job to save my life. The skill of these women is unbelievable. The speed with which they work is incredible. And in many ways, they're the unsung heroes of the PPE business. And you might be wondering, well, you know, we got to get those jobs back to America. If disposable clothing were made in America, it would cost 10 or 15 times more. It's very costly to make disposable clothing by hand. If there's a way to do it by machine, it can be affordable, but very hard to get people to do this kind of work in America. I thought this, I like this picture because the woman smiling, I think there's not been a lot of people that have visitors to the factory that took that much interest in. And so I think that she was pleased that that someone from another part of the world that uses these products was taking interest in the work that she does every day. And again, you know, I don't know if that was her first hour or her 12th hour of the day, but she works awfully hard. And we have, in many cases, women like her to thank for all of our disposable clothing. I'm concerned about disposable clothing. I'm concerned about it because we are having a very, very hard time replenishing our stock, and we see, we may not see an end to that problem for a while. Disposable clothing is really a troubled market. The sewers are all getting 2 to 4 times what their normal pay is. I heard one factory had to pay 5 times their salary to the workers. The raw material, and it's very hard to train new workers because it's very skilled labor. The raw material is also in use by face masks, that non-woven material. The pricing that we're getting to replenish our stock is, in some cases, 20 times, not 20%, but 20 times what we used to pay. In some cases, 10 times. But I mean, the price of replenishing our disposable clothing is astronomical, and so we're dealing with that. We're working through it, and it's quite a challenge. The stories we're hearing is that the raw materials are going up 10, 20 times. So it's been very tough. I want to talk, I'm running out of time because I want to get to Q&A. I want to talk about PPE price increases. I think it's important. As I mentioned to you, anytime we get any finished good from China or any part of the world, there's been several factories involved. There's the raw material factories that supply the raw material factories, which supply the raw material factories. And then there's the finished goods factory. And think of it as a chain. And at every link in the chain, in a crisis, there's two types of price increases. There's legitimate price increases. For example, if the workers are demanding 4 to 5 times the pay to come back to work, that's a legitimate price increase. The factory can choose either not to make them at all or to pay the higher cost of labor. If the raw material factory is charging 5 times, I'm hearing that for the middle layer of masks, they're charging 80 times what's normal. If the factory chooses, they can either buy material or not make the masks. So that's a legitimate price increase. But also along the chain, there's price gouging. So there's no two ways about it. You might think when you see the pricing as it comes in from the distributor, that it's all the distributor's fault. It is absolutely not. In our case, we have our margins dialed back on these products. Our margins are lower now than they used to be before this crisis. But it seems, dentists are used to paying $5 to $10 for a box of ear loop masks. I think we might be seeing prices of $20 to $30 for a box of ear loop masks until this crisis ends. And it's not the distributor's fault. It's that chain and the legitimate price increases, as well as the gouging, which is all part of the chain. The gouging doesn't happen on the last link, at least as far as Binco is concerned. So get ready and buckle your seatbelts for big increases in PPE prices that I think will be with us for the next 6 to 18 months. In some categories, more than others. I want to talk about China and other worldwide partners. I think that China does get a lot of bad press. A lot of it they deserve. I would say, though, that in my experience in China, there's some rotten people in China, just like there's rotten people in the US. But for every rotten person, there's hundreds of wonderful people. And they really do, they work very hard for us. And they really do their best. At the other end of the world, they've got families to feed as well. Some of them are in the game of gouging right now. Definitely not all of them. And I just think that some of the press that China's getting is deserved and some is not. Some of the PPE is not going to come back from China unless we can get automated factories making them here in the US. Face masks will come to America, in my opinion. I believe that the face mask business in the US, we've always bought 70% of our face masks in the US, and more capacity is being built right now in the US. Why? Because you can automate face masks. You can fully automate face masks. You don't need too many people involved. But when it comes to hand sewing clothing that you're looking to sell for $1 or $2 per piece, you can't do that in America. It would be 10, 20 times or more expensive. So we need to depend upon the countries with low-cost sources of labor to get disposable clothing that is affordable. And so that said, I just want to, I've got a couple of notes on how the PPE supply, how and when the PPE supply chain will normalize. I'll spend 2 minutes on this and then we can open it up for questions. So it really is by category. I think it will take face masks 6 to 12 months. I think that it'll ease up in China, and we'll get more and more good supply out of China in 3 to 6 months. And then I think it's going to take 6 to 9 months for the US mask factories to build the machines that are necessary to take up all of that capacity. And then I think most companies are going to do what Binco's been doing forever, which is buy about 70%, 60, 70% of our face masks right here in the USA. So you're going to see a lot of mask capacity built in the USA, but it'll take some time to normalize. I think disposable clothing will stay overseas until someone can make capable machines that do it in a fully automated way. To my knowledge, I don't know of anybody that's doing it in an affordable way. I will tell you that I was very encouraged. In the first 2 weeks of this crisis, there was a huge problem with hand sanitizer. And good old-fashioned American ingenuity, we solved that problem. Hand sanitizer, in 2 or 3 weeks, not months, not years, but 2 or 3 weeks. There's plenty of hand sanitizer in America right now. And why? The distilleries have all gotten into the hand sanitizer business. So this is from a Pennsylvania distillery. I guess they're making a little bit less booze than they used to. That's a problem for some of us. But they're in the hand sanitizer business now, and it's great for all of us. That problem, thanks to American entrepreneurship, solved. And I think that we're going to see the other categories resolve themselves over the next 3 months, in some cases to 18 months. But we've got a long road ahead of us. N95s will take some time, everyone. So that said, we can go over to questions. I'm mostly on time.
Mostly on time.
I just want to remind everyone to please make sure, we're here to answer your questions. Please use the Q&A at the bottom and type in your questions, because I mean, if you have any at all right now on PPE, I think Rick is going to be the best person to ask. So please type in your questions at the bottom. Thank you. Go ahead. Good, Jim.
Thanks, Kay. Rick, there's a question about billing. Are dentists going to be able to use a billing code for the extra cost of the PPE per patient? Do you have any information about that?
There's lots of talk about that, and we're hearing dentists begin to charge PPE fees somewhere between $8 and $15 is what we're hearing. We're hearing about ADA codes that are coming out, and I think that Kay would be a great person to ask if there's anything concrete. To my knowledge, it's not yet concrete, but a lot of dentists are charging for it.
Actually, at the end of this webinar, we have an expert on. We have Roy Shelburne on. Dr. Shelburne is going to be able to tell you the cost and what's going on. Some insurances are telling you not to charge for it. They're going to send you a check at the end of the month, depending on how many patients you saw. Some are saying charge for it. So I'm super glad you asked that, and Roy will make sure he answers all those questions. Thank you.
Rick, I don't know if we wanted to talk a little bit about specifically in Texas. The Texas state came out with an order saying that the dental healthcare workers have to wear an N95 respirator mask or a K95 mask if they're anywhere within 6 feet of an aerosol procedure. And then they came out with a second statement, and they said, when we say, or you can use an equivalent, when we say equivalent, we're not talking about a face shield and a level 3. That's not equivalent to a KN95 or N95 respirator mask. But I know we were looking for clarification from the dental board in Texas on that. I don't know if you want to speak to that, where that's at.
My expertise is supply chain, Jim, and it's not my place to talk about the best way to protect yourself in Texas and still be in compliance with the Texas board. So I'm not going to answer that one. I can't answer it.
Okay, so another question here. It says, ABC Dental is facing rations on PPE. Do you think there to be an even greater shortage soon, reducing the current rations on PPE?
I think it depends on the category. I think there's going to be a tremendous shortage of disposable clothing that's coming our way. I think we're going to see tremendous price increases on disposable clothing. I think that the KN95 problem will ease up in the next 2 or 3 months we've already seen tremendous loosening of KN95s in the past 2 weeks from good sources that are on Appendix A. And you want masks that are on Appendix A if you can get them. But we're seeing more and more good KN95s coming out of China at a lower price. We've seen, in fact, 30, 40% price reductions. So that's good news for our industry.
There's a question on the difference between a K95 and a KN95. Why is the mask so much thinner? And also, they are very loosely fitting, especially around the chin area. What can we do to use them and still feel safe?
A K95?
A KN and an N95. The difference they're saying is that it's so much thinner. The KN is so much thinner than an N95.
So if your KN95 is so much thinner, it may not be authentic. And what the Wall Street Journal and the New York Times say is that 60, 70% of the KN95s that are called KN95s are not authentic. So when I'm hearing that it's thinner, I'm skeptical that it's real. So I'm not sure where you got that KN95, but I would strongly recommend make sure you're buying your KN95s from a reputable supply chain, a company you know and trust, because those are the companies that are going to have regulatory departments that are going to do the homework. Even 3M said that a good KN95 is every bit as good as an N95. Now, if you have a good KN95, the best way to protect yourself even more is to get one of those headbands and to make sure those ear loops are tight. With a headband, you can really get the mask stuck on your face in a really tight way, which limits the amount of unfiltered air that gets in through the side, and that's what we would recommend. So I hope that answers your question.
Okay, the next question is one that I could probably answer. They want to know, what is Appendix A? I think you referenced Appendix A earlier.
Yep.
Appendix A is a list that the FDA publishes in conjunction with CDC and NIOSH. They test these KN95 respirators, and if they pass the filtration test of 95% or greater, FDA adds them to the list. Question, someone wants to know, do you need a fit test?
So I'm going to let you answer that one, Jim. I know the laws have recently changed on that. There are OSHA laws related to that. So why don't you take that one?
Okay, so OSHA is the one that has the law around fit testing respirators. When you use a mask that's a tight face-fitting respirator, it's meant to give you a tight seal, OSHA says you have to do a fit test. So if it's not a tight fitting around the face respirator, like say an example of an ear loop mask or a KN95, it would not be required to do a fit test.
Very good.
So there's another question here about price. What exactly is the list on each piece of PPE supposed to be worn per patient? Can anything be worn again for dental hygienists? I think they're talking about reusing PPE.
So most of the PPE items that we sell were not designed for reuse. However, those were in different times. I mean, when the pre-COVID days, when you used an N95, it wasn't to be used for a month. And yet in acute care centers where they're dealing with COVID patients, there's a lot of healthcare workers that are using the same N95 for weeks or months. So we are forced to do unusual things in these unusual times. There's lots of talk about how to sterilize N95 masks. You know, it's all recent talk. There's not a lot of studies that have been done on it. I've heard that a UVC light can help, but you will not get enough KN95s or N95s, as many as you wish you can get. Unfortunately, we simply can't get enough. And that problem should continue. You also asked about price. Price changes weekly for us. We're slaves to the factories in China and the shipping to get it here. So, you know, whatever the cost is in China actually changes day by day, week by week. We do the best we can to get them at the lowest price we can. And then we have to get them here. Usually they get put on a 747, which is an extremely expensive way to get stuff from China. it usually doubles our cost. And that's why we're going to see pricing on masks, KN95s, it's in the $4 range. It's a funny thing though. We're also going to see pricing on N95 masks from companies like 3M at $1 a piece. So that's weird. You're scratching your head. A KN95 from China, which is definitely not as good as an N95 made by 3M, is 4 times as much. That doesn't seem right. And you're right, it doesn't seem right. But 3M, they're charging the same price today as they charged pre-COVID. In China, they're generally selling to the highest bidder. So there's lots of people all of a sudden that got into the mask business and they've been bidding up these KN95s. And that's why the KN95s are so much more expensive than the 3M N95s. The problem is we can't get 3M N95s because they're all that supply is controlled by FEMA and controlled by the federal government. So, but I think we'll be getting them soon. And that's part of the reason why I think this whole market's going to normalize.
Okay, one last question. Is it safe to wear the KN95 and have a severe asthma problem? And I can speak to this because it's mentioned in the Osha guidelines when they're talking about fit testing on N95s and other masks. If you have any kind of a breathing impairment, respiratory problem, COPD, asthma, they advise that you check with your primary physician first. Let them know that you're going to be wearing a mask for an extended period of time during the day, and they can give you the best advice on that.
I will tell you that, Jim, I have lifelong asthma, and it is a different experience wearing an N95 all day long during stressful times of asthma. So that is a real concern.
All right, Kay, the rest of the questions will be addressed if we didn't get to them in the full sheet copy to be emailed at a later time.
Fantastic, great job. You know, Rick, it's always a pleasure to have you on. You have so much information. I could listen to you all day. So thank you so much for sharing all that information with us. We are so lucky to have both brothers on. So we absolutely had both managing directors for Binco Dental on. So that's how much they care about their company. It really does mean a lot. So Rick, you did an amazing job. I just want to remind everyone again, keep those questions coming in. And if we don't get to them during the webinar, we will make sure that they get answered. Our goal is to make sure that we answer all of your questions for you. So with that being said, I get to introduce Chuck Cohen, the other brother, and Chuck is going to do the introduction of our other speakers. So Chuck, you're on. We were actually waiting for you, Chuck.
Oh, well, thank you, Kay. I appreciate that. Rick did a great job as always. He's one of the most knowledgeable guys out there on the PPE market, and it's always great to see his photos and have hear what's really going on over in the Far East, because most of us don't even know that. So thank you, Rick. It's my distinct pleasure to introduce our next two speakers, Dr. Marie Fluent and Michelle Lee. Michelle is the longtime executive director of OSAP, which is the #1 agency and nonprofit that gets involved in infection control issues in dentistry. So we're very lucky to have her this evening. And Dr. Fluent has been practicing for more years than any one of us probably want to admit. She doesn't have gray hair, but she's got a lot of experience. She's a practicing dentist, a former associate, a former assistant. She's worked every job there is in dentistry. And Dr. Fluent and Michelle are going to work together to help us understand better the infection control protocols post-COVID-19. Ladies, thank you for being here with us this evening, and we're glad to have you.
Thank you, Chuck and Rick. And Michelle, are you there?
Yes, I am here.
Have I successfully shared my screen?
No, it's just showing
You had
your
it up on the go. I
desktop.
think
You had it
that's-
up.
Yeah, I think you just took it down. So you can just reopen it. That would be great.
Okay.
Yeah. That's it.
Got it?
Yes.
No, there you go. Now, if you don't mind, just go in the bottom right corner and just click on it where it's slow. I think it's fine. Now that'll work as long as it's moving forward for you.
Are we okay?
There, that's great.
Okay, go ahead. Take it away, Michelle.
Well, I am just going to do a brief intro real quick, and I'm going to talk at the end. But thank you to Binco for inviting us today. As Chuck shared, we are a membership association. Our total focus, we are the only dental association that is focus totally on dental infection control. And I'm so excited tonight that one of our longtime OSAP members and one of our subject matter experts on dental infection control, Dr. Marie Fluent, is with us to talk with you about the Texas specific mandates. And we're going to talk a little bit about how OSAP tools can help you along this journey. So I will turn it over to you, Marie, and then I'll come in at the end.
Sounds great. Thank you so much, Michelle. And without further ado, here we go. Short disclaimer, no honoraria is being received for this presentation. And like Rick, I want to share with you that I'm not providing legal advice, nor am I providing medical advice. If you have any questions in those categories, I urge you to seek professional medical care or legal advice, legal counsel. I want to talk to you a little bit about the regulatory bodies that impact the practice of dentistry in Texas. You have your Texas State Board of Dental Examiners, and of course, we've got lots of other agencies that impact dental care as well. We're going to talk a little bit about transmission-based precautions versus standard precautions. And up to this point, we have practiced using standard precautions, and now we need to up our game a little bit and address transmission-based. Personal protective equipment recommendations. I know Rick did an excellent job covering the availability issues, and I'll go over some of the regulatory issues regarding PPE as well. And then I'll give the mic back to Michelle, who will talk about a little bit about OSAP and the resources and tools that OSAP can provide to all of you as well. So with regard to compliance in Texas, first of all, you have your government orders, and reopening was allowed effective May the 1st, 2020, and reopening is optional. In other words, if dental offices feel they are not prepared, they are able to use their professional judgment and say, hey, not yet, we need to wait a little bit of time. The Texas Board of Dental Examiners has an emergency rule, and they ask that we follow CDC guidelines and conduct dental practices according to the minimum standards for safe practice. So if dental practitioners wish to go up and beyond the call of duty, they are certainly able to do that, but they must practice and abide by the minimum standards for safe care. Then Texas also is obliged to practice under the federal OSHA plan. And according to the government orders, with the Texas State Board of Dental Examiners, this order may be modified. For instance, if we see a sudden resurgence in COVID-19, your orders may change, and it's up to dental practices to keep updated as these regulations may be modified in the future. So the transmission of COVID, I'm sure we're all pretty much up to date on what those might be. And the main symptoms include the fever, runny nose, cough, and it may be a dry cough or a productive cough. But there are new symptoms as well that we need to be familiar with. They include fatigue and loss of taste and loss of smell. And unusual rashes are popping up, particularly in pediatric patients. I do want to point out that up to 25% of those infected with COVID remain asymptomatic. And that to me is the most scary and crazy making part of this disease, that we can have people running around in grocery stores or pharmacies or out in public, not know they are sick at all, and yet be transmitting viral particles to the rest of us. And that's scary because those people can also enter our dental facilities and past our screening protocol. So as a result of that, the Texas Dental Association and Texas State Board of Dental Examiners wants us to all assume that all patients can transmit diseases. So we need to consider all patients as potentially infectious. Now, I like to think about droplets and airborne spread of diseases similar to rain versus fog. CDC describes large droplets and small infectious droplets as particles that land quickly, and they can only spread 1 to 3 feet or 3 to 5 feet at most. And that's why when we are asked to socially distance, we are asked to be about 6 feet from each other. And I equivocate these to raindrops or drizzle particles if you will. But infectious droplet nuclei or aerosols are an entire different breed. In this arena, I think of fog. And when you think of a foggy day, you think of these little aerosolized particles that can spread very, very far and stay suspended in the air for a very long period of time. And that's what we're dealing with COVID-19. We're dealing more with the fog than the rain. So as a result of that, we need to shift our practice from standard precautions to transmission-based precautions. We still have to practice standard precautions, which includes hand hygiene, respiratory hygiene and cough etiquette, sharp safety, how we handle our sharps, sterile instruments and devices, and cleaning and disinfecting of our environmental surfaces. Now we need to take it a step up and beyond that and look at transmission-based precautions as a result of this fog that I described on the previous slide. And this may include an entire respiratory protection program, including a fit tested N95 mask or higher level respirator, and ideally keeping our rooms closed, which is a problem in dentistry because most of us have an open concept design. We need to educate and train our dental personnel on what COVID is about and what is our risk on the job, how the disease is transmitted, personal protective equipment to protect us from disease transmission, respiratory protection, screening. Screening includes both of patients and dental healthcare personnel. I already talked about transmission-based precautions and unintentional exposure incidents. And by that, I mean you have a patient who comes into the facility, they pass our screening protocol, they're one of these people who may be pre-symptomatic or asymptomatic and yet shedding viral particles, and lo and behold, they call the office 5 days later and say, guess what, I'm running the fever and I really think I've got COVID. Now the entire office has been exposed. What do you do? Well, there is protocol on the CDC website about unintentional exposure incidents, an exact protocol and like an algorithm on how to handle those situations. But we need to be aware of that because those days are coming and we're going to see that more and more. Now, the ADA came out with a return to work interim guidance toolkit, which is a phenomenal resource, and I encourage all of you to get a hold of it. You can download it free of charge from from the internet, and much of the information in this return to work guidance toolkit pertains to Texas, but I want to let you know there are a couple of discrepancies, and I'll point those out as we go along, so bear with me here. First of all, you need to prepare an office manual, and this would be a great template and a starting point for you. You can use this whole toolkit as a template. It contains sample forms, sample scripts for patient communication, and we encourage everybody to rehearse, get your whole entire dental team together and rehearse donning and doffing or applying and removing PPE, how the patient flow is going to occur. Obviously, we're going to phase in and start a little bit slower before we ramp up into full speed care. We're going to talk about timing for operatory usage, sterilization routines, and of course, per OSHA, we need to document all of our training that has occurred. Now, as we prepare our offices for the reopening, most offices, I'm under the impression in Texas, have already reopened, but removing of toys, magazines, and other objects that you can touch frequently in the reception room should be removed. Cleaning and disinfection of the household surfaces, and that includes doorknobs, countertops, sinks, handles, anything that you would touch and share with other people should be cleaned and disinfected on a regular basis. And your clinical contact surfaces should be cleaned and disinfected, or we should apply barriers to protect surfaces per CDC guidelines. Then signage should be placed in your reception room, and most of these signs can be downloaded free of charge from the CDC website. And the poster that I have displayed on the right-hand side talks about COVID and informs patients that if they have any of these symptoms, they should notify front desk personnel. And of course, we're going to enforce social distancing in our offices as well. Also consider putting signage in the restroom, just like they do in restaurants, informing staff and patients to wash their hands before returning to the office. Now, there are other considerations for dental personnel that include medical conditions and work-related illnesses. So we are screening patients, yes, but we also need to screen our dental personnel. So dental personnel, including everybody in the office, should not report to work if they have any type of influenza-like illness. And that includes fever, sore throat, cough, muscle aches, or any of the symptoms that I described on the previous slides. People who have a higher risk of COVID disease or severe disease include those who are older, if you have dental personnel who are 60 plus, or those who have pre-existing medical conditions, and that would be diabetic, people with heart diseases, high blood pressure, immunocompromised for whatever reason, including cancer therapies, they would be considered at a higher risk for severe COVID disease, and perhaps you want to include those who are not in that category to be prioritized for patient care. Now, pregnancy is another story. Our research on, or the availability of literature about pregnancy and COVID is really not understood well. CDC has a great page on that, and you can also consult with your physician if pregnancy is a consideration in your practice as well. Dental personnel should monitor themselves for respiratory symptoms and check their temperatures twice per day. And that ADA template provides a great log to check your temperature and screen on a regular basis. Now, here's a bullet point on the bottom portion of this slide that's unique to the Texas Dental Association. We want to ensure that dental personnel have received their annual flu vaccine. Keep in mind the flu season is over now. It's done in May, but in the autumn when it picks back up again, encourage all of your team members to have the influenza vaccination. Now, we talked a little bit about pre-screening protocol, and we'll be screening our patients over and over again, so bear with us because this is part of the protocol. As patients are given an appointment, they undergo a pre-screening appointment, or that can occur at the confirmation point as well. Once the patient comes into the office, then they will be screened yet one more time. So the screening includes taking of the temperature, consider dentistry, where you are performing these screening questions via the telephone or any type of text messaging. And also you need to screen anybody else who comes into your facility. So if you have a parent accompanying a child, or a laboratory technician who's dropping off a lab case, or your friendly neighborhood Binco representative who's entering your facility, guess what? Bring out your thermometer and pre-screen them as well. And we're trying to limit the patient companions as much as possible. Sometimes it's not possible. If you have a patient who has special needs, obviously they will need a companion. A child will need an adult, but try to limit and minimize as much as possible. And of course, maintain confidentiality. The reception area is going to look a little bit different as offices reopen. Once again, we're going to observe social distancing, no handshaking or touching of patients, get rid of any type of frequently touched objects, even pens or pencils. Front desk personnel are encouraged to perform hand hygiene with an alcohol-based hand rub often. Gloves are not recommended for front desk personnel, and surgical masks and eye protection are recommended. And when I say surgical mask, I mean an ear loop mask, as Rick was describing earlier. Front desk personnel do not need to wear an N95 mask. Better option would be to place a barrier, a plexiglass or a glass barrier if you can. Consider phone headsets, because once again, that's an object you don't need to touch. And we already talked about a virtual waiting room. Offices may also consider waiving their last-minute cancellation fee if a patient calls and says all of a sudden is running a fever and we don't want them to come in. If you consider the last-minute cancellation fee, it might avoid a little bit of a conflict of interest on their part. Patients are urged to wear any type of cloth covering and perform hand hygiene upon entry of the facility. Now, personal protective equipment, we need, of course, a good stock of gloves, eyewear, gowns or jackets, face masks and surgical masks, face shields, foot covers and head covers. When it comes to foot covers and head covers, we're urged to use our professional judgment. ADA and CDC do not really have an opinion or sound guidance regarding head and foot covers. We will be going through much more PPE than we had been in previous COVID era. So CDC provides a personal protective equipment burn rate calculator, and it's a spreadsheet to help you figure out what you are going to need in the weeks ahead. And of course, as we already know, PPE is in short in supply, and we need to consider the lag in supply chain as well. So use that as a tool to help anticipate what your needs might be in the upcoming weeks or months ahead. Now, mask types, Rick already went through this, and this slide shows the differences between the N95 and K95. And this slide was put out by the American Dental Association. And I already see one mistake right up front and center. Rick pointed out that a true N95 mask does not have ear loops, whereas a KN95 mask may have ear loops or a headband. And in this picture, you can see the American Dental Association drew an N95 with ear loops. So disregard that they're showing an imposter, if you will. But with this slide, I want to point out two things. The Texas State Board of Dental Examiners says substantially equivalent to N95 and K95 does not mean the combination of a surgical mask and a face shield. And this was one of the questions that was posed to Rick earlier. So if you are performing clinical dentistry, you're in the operatory as dentistry is being performed and care is being provided, a surgical mask is not for you. You need to have an N95 or an equivalent. According to the Texas Dental Association, you are to use the highest level of personal protective equipment available when treating patients to reduce the risk of exposure. But follow the Texas State Dental Board of Examiners if providing clinical care. You need an N95 or higher because we are assuming that all patients are potentially infectious. Now, the surgical mask you see on the left-hand side, those would be reserved for people in your office who are not involved in clinical care. Those may be worn by front desk personnel. We're having our patients enter the facility wearing a cloth covering, but if they do not have one, they could wear a surgical mask as well. Don't give them your N95s or alternatives. We need to reserve those for dental personnel providing care. This slide, the area that I have highlighted on the right-hand side shows the FDA authorized manufacturers that we were discussing earlier. That's the Appendix A for acceptable alternatives at this time. Rick already talked about counterfeits, so I won't belabor the point, but these are some things to look for and to identify a counterfeit mask. Now, the donning and doffing of PPE is important, and the order in which you don and remove PPE is important. And there are posters and descriptions available on the CDC website that describe exactly how it should be performed, the order it should be performed, and where it should be performed. My advice is that when you get your dental teams together, that you practice. Everybody picks a buddy, you're on a buddy system, you go through the chart together, and don and doff PPE facing each other, critiquing each other, so you really get this down pat. It's a little bit more complex than what we've been used to, so I would encourage a dress rehearsal, so to speak, before the real time. Now, just because you're wearing an N95 mask does not mean you have a full respiratory protection program. You need a true respiratory protection program that addresses other aspects of transmission-based precautions. So this program must be comprehensive. It must be written per OSHA standards. Fit testing is required. Training, a medical exam was addressed during the Q&A portion, and a seal test. Now the fit testing, there's several components to a fit testing. First is initial fit testing when you first start wearing an N95 mask to make sure that you're wearing the right size for you. One mask does not fit all. Faces come in small, medium, large, extra large, etc. And we need to assure there's a tight seal around the entire perimeter of your nose, cheek, chin area. So an initial test, a fit test, is still required, and now OSHA has waived the annual fit testing requirements because we are now in this crisis mode. But each time you put on an N95 mask or an equivalent, you should perform a seal test. A seal test is where you exhale or inhale abruptly and rapidly, and you put your hands 12 o'clock, 6 o'clock, 3 o'clock, 9 o'clock around the perimeter of the mask, and you're feeling for any gross leaks that may occur when you've got that mask on. And if you can feel a puff of air when you breathe out, you don't have a good seal. You may have to adjust it, or you may have the wrong size. So these are all components of a complete respiratory protection program. So now we're entering the operatory. We need to don our PPE before we enter the operatory. The ADA says, consider updating our informed consent. The reason is that we're minimizing our risk of exposure, not eliminating our risk of exposure, and a chance of exposure and a disease transmission still does exist. So consider that language and check with your malpractice carrier to see if you need to modify or not. We're going to try to minimize any type of clutter or paperwork in the operatory, use barrier protection for computer keyboards, limit access to the operatory when possible, keep the number of staff minimal, one dentist, one assistant, or in your hygiene operatory, one hygienist. And now's where you might think through this as a team. Maybe you want to designate one member on the team as a rover, somebody to go retrieve an extra instrument or extra dental materials if you need it, rather than your clinical staff up and leaving the operatory. No handshaking, physical contact, hand hygiene, and donning gloves in the operatory. Review the health history and your screening questions once again. And here's one area highlighted in red where Texas is a little bit unique. According to CDC, a pre-procedural mouth rinse, there's no evidence that it prevents disease transmission. Texas says, we don't care. If the patient is able to, we want you to rinse anyway. So it is recommended that a pre-procedural mouth rinse, particularly with 1 to 1.5% hydrogen peroxide, would be your best bet. Now, hand hygiene is, we're going to be performing that many more times throughout the day. The key recommendations have not changed, so I will not go through these, but TDA says that strict adherence to hand hygiene includes before and after contact with patients, after contact with contaminated surfaces or equipment, and of course, after removing PPE. Our front desk personnel are going to be performing hand hygiene, so are our patients and our guests upon entering our facilities. Now, during patient care, we're supposed to use our professional judgment and employ the lowest aerosol generating armamentarium. What that means is use your high-speed handpiece as minimal as possible. When it comes to ultrasonic scalers and the dental hygiene arena, at this point, we're asked not to use them, nor our polishing jets, etc. Use four-handed dentistry and HVE, high velocity evacuation systems, and extraoral suction devices. Use a rubber dam if possible. And if you're going to use nitrous oxide, they recommend a disposable nasal hood, and the tubing should either be disposable or reusable. And I find this interesting because I practiced dentistry for 25 years and I don't remember doing either, but we're asked to be on the lookout that for disposable or autoclavable at this point. Now, once the patient exits the facility, once again, they're performing hand hygiene with an alcohol-based hand rub. They're supposed to leave the operatory and the office with their cloth covering or a mask, and we're asked to have the patient report any signs or symptoms of COVID-19 within the next 14 days. It might be a good idea to implement a policy within the office where we have patients, somebody from the facility call and check up on the patients maybe 5 days after or 14 days after and inquire as to their well-being. Now, after the patient is dismissed, we're supposed to clean the operatory wearing gloves, masks, face shields, or goggles, and of course, follow the CDC guidelines for environmental infection prevention. We'll dispose of any surface barriers, clean and disinfect our clinical contact surfaces. And the area that I highlighted in red is an area that needs attention right now. We're supposed to be using products that meet the EPA, Environmental Protection Agency's criteria for use against SARS-CoV-2. And all of these are available on the EPA list. You can look up your product. Chances are, if you're already using an intermediate level surface disinfectant, that it is on this list, but no harm in double checking. And of course, whatever product you use, make sure that you follow the instructions for use. We talked about replacing the surface barriers with clean hands or clean gloves, obviously, and cleaning the evacuation system per the instructions for use. Now, clothing, gowns, clinic jackets, disposable gowns, we talked about those, discard after use. Cloth gowns, they should be laundered after each use. And obviously, we're going to be going through a lot of PPE, and a lot of questions have arisen in this area. Scrubs should be changed as all other office garb between street clothes upon entry and exit of the facility. So when you come to work, you're in your street clothes, you change at the office, put on your scrubs. At the end of the day, do the reverse. And ideally, you're doing the same with shoes, leaving shoes at the office. And if you have to wear your shoes home, try to disinfect them. Laundry facility should be provided in the office, or we should be contracting with a laundry service who takes our reusable gowns out to be laundered. Now, we talked a little bit about an unintentional exposure incident, and those would be for situations where a patient passed the screening process, but 2 days later they said, yeah, I've got a fever and I suspect I have COVID. Now, what do? I have the link on the bottom of this slide, and this is a CDC webpage that provides an exact algorithm and chart on what to do if you had an inadvertent exposure incident. And it depends on what your level of personal protective equipment would be, how long you were exposed to the patient, and if any aerosol generating procedures were performed or not. So follow that guidance, because the time will come when you need it. Now, there's COVID testing in dentistry, and I'm sure you have all seen the American Dental Association had lots of people signing petitions to be able to provide testing in their facility, same with the AGD. Now, the Dental Practice Act does not give the dentist the ability, such as serology test or molecular test, for the virus itself. These are considered medical tests. So there are very many concerns about accuracy. There are many of these tests that are gray market, and we cannot really depend on the accuracy and the specificity, that's a hard word to say, how specific the test results might be. So the American Dental Association advises dentists to follow the FDA for testing practices and see your state health department website for your specific area's recommendation. So according to Texas, your recommendations are that if you would like to, you may, but be cautious, and it's not mandated, and really educate yourself before you delve on into COVID testing in your facility. So here are some policies that are unique to Texas. First of all, dental personnel must complete the full treatment of one patient before leaving the treatment area to treat another patient. So in other words, if I'm a general dentist and I'm seeing an operative patient performing a crown preparation, and I have a hygienist who's asking for a hygiene exam for her patient, I cannot up and leave and perform the hygiene exam and come back to my own patient. I need to complete the full crown preparation, remove my PPE, perform hand hygiene, dismiss my patient, or let my dental assistant dismiss my patient, and then I can devote my full time and attention to the hygiene patient. So in other words, no jumping back and forth. We already talked about substantially equivalent to N95 and K95, and that does not mean the combination of a surgical mask and a face shield for clinical personnel. Front desk personnel may wear a surgical mask. N95 or equivalent are required to be worn within 6 feet of any aerosol generating procedure. Patients to perform a pre-procedural mouth rinse if they are able to. For hygiene, use a slow speed polishing and hand instrumentation only. The dentist must notify patients if a staff member tests positive to COVID-19. And once again, you can use your screening log to identify all patients who must be notified or any staff members who need to be notified. We must report a patient or dental health care personnel to a local and state health department if they do test positive for COVID-19, and keep in mind that all of these standards are subject to change. Now, here's something unique to Texas, and it involves hygienists and hygiene services versus hygiene procedures. Hygiene services include routine prophies, child or adult prophies, and in these situations, we cannot use ultrasonic devices. Now, for hygiene procedures, these are our periotherapies, scaling and root planing, etc., and we may use ultrasonic devices if it is deemed medically necessary as a part of the dental treatment plan. So this is where we need to keep our coding really in check. We need to be aware of our hygiene, routine hygiene codes versus our perio codes, and we need to document. So keep that in mind as well, and this is kind of unique to Texas. The Texas Dental Association has a great web page on reopening your practice, and this is just a screenshot of some of the resources that are available to you. It includes screening protocol, transmission-based precautions that we just described, what dentists must do, frequently asked questions, PPE, etc. So encourage all of your clients, and if you're dental personnel, really utilize this website. I went through it and I think it's a great resource for you. But speaking of resources, I'm going to bring Michelle Lee back to talk about OSAP as a resource. Michelle?
Thank you. That was excellent, Marie. And I'm just going to take a few minutes to tell you all about OSAP, again, with the Organization for Safety, Asepsis, and Prevention. Our vision is that every dental visit is a safe dental visit. And our goal is to be a leading provider of infection prevention and control education in dentistry. If you'll go to the next slide, Marie. Thank you. So we want to share the resources that we have on our website. The website is osap.org, osap.org. And on that website, we have all kinds of what we like to call toolkits. And I believe that our COVID-19 toolkit, it's probably the most comprehensive toolkit that anyone has on their website. We have a subject matter expert, a dentist that works for us full time, who is constantly updating that information. And she also handles our Ask OSAP section of the website. So in your daily work, I always like to say, more than the thermostat, or maybe not more, but equal to arguing about the thermostat in your dental practice, the next thing we all argue about are infection control questions. And so if you have a question that comes up, you can submit it to Ask OSAP, and we will usually get a answer back to you. We say in 3 business days. I hope she's not listening to me, but I will tell you she usually gets an answer back to you within a day. I'm going to share in the Q&A, I'll put a link. One of the things that I know it's on our site, but in some of the discussion about the counterfeit mask, NIOSH has offered to, if you do receive order mask and you didn't get them from Binco, so you're not sure if it truly is a KN95 or an N95, you can actually send them a sample of that mask, and they will test it and let you know what the filtration rate is. And they also have on this site a list of all of the masks that they have already tested, so you can compare. And it's really interesting because some of these tests are showing that it says it's an N95, but yet the filtration is only at 37%. So that's another great resource, and we have it on our website, but I'll add it to the Q&A so that you'll have it available for you. Right now, normally a lot of what we have on our website is locked down for members only, but when the COVID-19 disrupted our world, OSAP made the decision to open up all of our member-only sections of the website to everyone. Because again, our goal is that every dental visit's a safe dental visit. So we wanted to make sure all dental professionals had access to all of our resources and tools. If you'll go to the next slide, Marie, please. One other thing that we're doing, we have launched this year the first ever certificate in dental infection control, and it's all online. It's a 3-step process, and if you go to the website, our microsite, I think that may be the next slide, dentalinfectioncontrol.org. Yes, you can find all the information about how to earn that certificate, and then in 21, you will be able to sit for the dental infection control certification program. And this is where it's a high stakes exam. You'll go to a testing center to take this test, and the certificate program is an entry into that, is one of the pathways. But you'll go and sit for that exam, and you'll be able to put, you know, just a few more letters after your name to show that you've earned that level of knowledge. And I think in this time, it's more important than ever that we all step up our dental infection control knowledge. If you'll go to the next slide. Oh, that's it. So we hope that this has been a benefit for all of you. And if you ever have any questions, just reach out to us. We're happy to help.
We do have a lot. Let me unmute. Hold on. We do have a lot of questions. So I think, Jim, you want to start going through some of the questions? We have quite a few. So let's see if Jim, you there?
Yes. Can you hear me?
Let's go through some of these questions.
All right. So first, it was a great presentation. I loved it. It was so full of information. It was fantastic. First question, and I think you covered this, but somebody asked, maybe they need to be reiterated here. Front desk reps do have to go to the back to speak with patients or staff. So do they not need an N95 if they go into the back?
Well, ideally, front desk personnel are going to stay put at the front desk. If they go within 6 foot of an aerosol generating procedure, according to the Texas State Board of Dental Examiners, then they need an N95 mask. So once again, make sure you have your whereabouts with you. If you are front desk personnel and you're staying at the front desk, your surgical mask is fine. If you hop between the clinical portion and the front desk portion of your office, then you're going to be changing PPE. To keep life simple, I would recommend staying put and letting clinical personnel retrieve anything from the clinical portion of your office.
Great. Do we have to use a new lab jacket for every patient, or is it okay to just change after an aerosol procedure?
That is the million-dollar question. As a practicing dentist myself, I'm no longer in private practice, by the way. I'm looking at this thinking, looking at the feasibility portion of this, as well as the infection control portion of this as well. And I'm going to say, according to CDC, you're going to change it each and every time, but feasibly and knowing that we have a shortage of PPE, that's probably not going to happen. So here's the rule of thumb. If you're involved in an aerosol generating procedure, a surgical procedure, you have contaminants on your clinic gown or your disposable gown, it would be no harm using it again until it becomes soiled or wet or contaminated, then pitch it, and obviously you are going to change at least daily. If you're involved in an aerosol generating procedure, change each and every time. Otherwise, or hygiene patients or checking an orthodontic patient, I would really optimize the use of my PPE. And by the way, the CDC does have a specific web page on the optimization of PPE at this time. Now that we are in crisis mode, I encourage all of you to take a look at that. There's a great page on optimizing the use of face masks and respirators, and another page on other PPE as well. And that is one strategy.
Very helpful. All right, this next question, there's many layers to it, literally, as you'll see in a minute. Can you reuse your N95 if you cover it with a level 3 mask and then a face shield?
Okay, that is not really recommended by NIOSH. And the reason being is that if you've worn an N95 mask or an equivalent, you're suffocating already. And if you add a level 3 mask, you're more than suffocating yourself. Not only does it impact the breathability of it, but you're also going to generate more moisture from within. And as a mask becomes wet, it becomes ineffective. So for those two reasons, that's not a good strategy. A better strategy would be to wear your N95 mask and wear a face shield on top, and then you have the full protection against sprays and splatters, as well as not impacting your breathability. Now, in the crisis mode that we are in, yes, you can re-wear your N95 or equivalent mask. I encourage you to look at the CDC webpage on strategies to optimize PPE, and these are supposed to be effective up to 8 or 12 hours. So yes, people are going to be wearing them, and as Rick mentioned earlier, these are short in supply, and so we do not want to throw them away each and every time after each and every patient encounter.
Great. So you talked a little bit about respiratory protection program, and this question is, what parts of a respiratory protection program need to be completed when we have no N95s available, such as fit test, which is not applicable to a KN95?
Well, here's a good suggestion for you, and I'm going to bring OSAP back into the equation. And Michelle, do you want to talk a little bit about the webinar that was done regarding a respiratory protection program?
Yes, OSAP did a webinar along with the ADA, and anyone can go and view that. It's on the ADA site. You do not have to be a member of the ADA. But Kathy Eklund and Eve Cooney from OSAP put together a webinar answering every question you can imagine about using respirators, covering the respiratory protection plan, and even went into counterfeits as well. So I definitely would suggest that. And they will be doing a third webinar for ADA next week on all of the CDC guidance. We don't have a date for that yet, but the new CDC guidance that was released today. So they'll be presenting that next week.
Right. Next question has to do with testing. And it says if an office decides to do testing, can you send it to insurance? Is it covered?
That is that would be a medical code, not a dental insurance code. So offices would need to be prepared to deal with that, and they would also need to have something called a CLIA waiver that allows them to perform laboratory testing in their facility. It's not a big deal to obtain that. There's an application and an application fee to do that, and then of course be prepared for the medical codes instead of the dental codes on top of that. Also, there's a lot of nuances to testing with regard to COVID testing. Yeah, we in the dental profession are perfect at collecting spit. That's what we deal with all day, but there's a lot more to testing than that. So we need to be really careful and cautious how we proceed. Dr. Michael Glick, who was the editor-in-chief of the Journal of the American Dental Association for many, many years, has a YouTube webinar on COVID testing for dental healthcare professionals. And I would encourage anybody who's considering performing testing in their facility to really delve on in and listen to Dr. Michael Glick. He's much more eloquent and educated on the topic than I.
Okay, so we have another question. It says, please explain slow speed, and can you elaborate more on what the test consists of to be able to teach it to other offices to stay safe and reopen?
A slow speed, I'm not sure what you mean by that. Do you mean like a slow speed handpiece? I'm not understanding the question.
I think when you were earlier, there was a mention of avoiding high-speed procedures like using hand scaling.
Okay. And this is going to be a tricky one because we're supposed to use our professional judgment to minimize aerosol generating procedures in the office. Now, as a dentist, you don't really, there's a big difference between a high-speed handpiece and a slow-speed handpiece. A slow-speed handpiece, if you're a patient in the dental chair, it'll feel like a jackhammer on your head, and you're going to feel the rattling from here to kingdom come. A high-speed handpiece is much more smooth, and it cuts much easier, quicker, but it generates more aerosols. So there's a fine line. As a practitioner, I'm not going to want to use my slow-speed handpiece instead of my high-speed handpiece because it will cause more pulpal damage, pulpal irritation, and possibly even pulpal death. So we need to be really careful of that. This is one area where being a dentist and a practitioner, we look at the feasibility and the practical side of it as well. So use your professional judgment. That's the best that I can say.
Good. Okay, so this last one we're going to do is reverse of the first question we asked. Sometimes I see back staff entering the front reception area. Any suggestions or precautions about this?
Once again, let's keep everybody separate. Social distancing in the office. We're going to have a dress rehearsal, talk to everybody about their role, where they're supposed to be located in the facility, what their job description is, and their risk really depends on their job description. So it's not just a matter of being territorial, it's a matter of your risk assessment on the job. One document that really spells that out well is the Osha guidance for returning to work in the era of COVID. It really talks about who's at high risk, very high risk, medium risk, and low risk. And where we're at in the office, our risk assessment will vary depending on that. So that goes into education and training of dental healthcare personnel and job description and risk assessment. So I think we're going to redefine who goes where in the dental facility in the era of COVID.
Yeah, no doubt. Thank you very much. That was excellent. Excellent. Back over to Kay. She can introduce the next speaker. Thanks.
Gotcha. Thank you
so much. That was really a lot of great information. And I just want to encourage everyone to keep those questions coming. Again, if we didn't get to your questions live, we will definitely make sure that you guys can email them the answers to their questions. So we'll be seeing over the Q&A. And anyone who's attending today will also get a copy of the Q&A. I even learned a lot. I've been on a lot of webinars and I was writing notes. So fantastic. Thank you so much. Thank you both so much.
Thank you.
So, Tim, you ready to go?
Yeah.
I'm super excited to introduce the next speaker who's been now a partner for ours for quite a while. And, I think that one of the biggest questions we have right now is, okay, so we have all this stuff. So what happens if our team members don't want to be compliant. Like what happens if, you know, they don't want to do this? What do we do with that? So I'm super excited to say that Tim Twig is a partner of ours with Ben Erickson, and he is going to talk about like some of your guidelines and what you can do specifically in Texas to make sure that you follow the guidelines that you need. Tim's been doing this for what, Tim, over 35 years?
Long time, yep.
I'm like 35 years old. Tim, you look great.
Thank
But that
you.
being said, I know that you're going to have a lot of questions too, so I'll let you go ahead and get started. But thank you very much for being with us tonight.
All right. So we're going to talk about this whole idea of moving forward and focusing on success. And so you've got 3 primary objectives, and one of those is to minimize any kind of risk of contamination. And Maria and Michelle just did an amazing job of talking about all of the infection control, OSHA, OSAP criteria, and what those new normals look like. The second key objective is to certainly instill confidence in the safety and the health and well-being of everyone, which includes your employees and your patients. And the third, of course, is to make smart, prudent business decisions that set you up for financial success. So a way to sort of distill that is don't rush, be smart, and focus on success. Your biggest challenges right now are just balancing all of the moving parts. And whether that's grants and PPP loans, or it's the unemployment anomalies, or it's everything with CDC and OSHA and the ADA, and again, all the new normals, the biggest challenge right now is balancing all these moving parts all at the same time. So what we're going to crank through here for the next little bit is these 4 agenda items. So first, we're going to talk about the FFCRA, then the CARES Act. We're going to talk about navigating the reemployment challenges, and then making a little sense out of employment compliance as it relates specifically to the FFCRA and reemployment. So in terms of the FFCRA, it's important to just, from a perspective standpoint, the FFCRA is really a wage replacement legislation. Everyone all gets hung up on sick leave and family leave, but when it's all said and done, it's really wage replacement legislation, which means if an employee loses wages because they can't work, specifically because of a valid qualifying reason, then this legislation is designed through sick leave and family leave to replace some or all of that employee's wages. The FFCRA went into effect April 1st. The bad news is it doesn't expire until December 31st unless Congress then decides to extend it, which just sort of extends the bad news. And from a bad news standpoint, you are not exempt. And we're going to talk a little bit more in detail about exemption in just a few minutes. The odds are between now and December 31st that some sort of COVID-19 outbreaks may crop up, causing some potential school closures or childcare closures, which will prompt some FFCRA requests leave requests that you're going to have to be aware of and navigate. There's also some posting, policy and forms requirements to ensure that you are crossing the T's and dotting the I's from a compliance standpoint. The good news is it does expire December 31st. So unless they extend it, we just have this window right now of about 7 months that this is going to be in our wheelhouse to have to deal with. There's very specific and limited qualifying reasons. That's also good news. This isn't just about someone having a cold or being sick in some other form or fashion. This is very specific to COVID-19. The third piece of good news is any monies that you pay out in wage replacement is reimbursed to you 100%. So any wage replacement, any paid sick leave or paid family leave that you pay out under FFCRA is reimbursed to you. Now, I mentioned that there are very strict and specific qualifying reasons. These are the 6. there is really nothing else that qualifies a person for being able to take advantage of the paid sick leave and the paid family leave under the FFCRA. Now, relative to this, the sick leave portion applies to any one of these 6. The family leave portion applies to only number 5. So family leave is only related to qualifying reason number 5. Sick leave is all 6 of them. In terms of the wage replacement, if the person is qualifying for numbers 1, 2, or 3, then what they receive as compensation while on leave is their normal wage up to $511 per day. And that's whichever is the smaller number. So if their normal wage is smaller than $511 per day, then that's what you're paying them. Similarly, for qualifying reasons 4, 5, and 6, then the compensation on paid leave is 2/3 of the person's normal wage up to a maximum of $200 per day. In terms of amount of time, if someone truly qualifies for one of the 6 and therefore the sick leave, they are eligible for up to 80 hours of sick leave. Now, the 80 hours is based on this person working full-time as defined by 40 hours in a week. If someone works less than 40 hours in a week, then they're not getting 80 hours of sick leave. It's prorated. Similarly, on the family leave side, a person can get up to 12 weeks of paid family leave under the FFCRA if they work 40 hours in a week. If they work less, then it's prorated. And a funny little nuance with the family leave is the first 2 weeks of those 12 weeks are unpaid. So drilling down a little deeper with that, if you have an employee, like we said, who works 40 hours in a week, then this person, as wage replacement under paid sick leave, gets 80 hours, which is the equivalent of 2 weeks worth, 40 hours for each week. Under the paid family leave, again, they get up to 10 weeks that is paid because the first 2 are not at 40 hours in a week. Let's say we had an employee who works only 30 hours in a week. Well, during that 2 weeks of paid sick leave, wage replacement is just 60 hours, 30 hours for each of those 2 weeks. And similarly with family leave, the person gets compensation of 2/3 of their normal wage up to $200 for 30 hours in a week for the 10 weeks. And similarly, if someone works 20 hours in a week, you can see that the numbers are just prorated accordingly. Relative to exemption, let's just work on sort of clearing that up. Is there a blanket exemption for small employers who have less than 50 employees? No. Is there a blanket exemption for dental practices in some way, shape, or form under the auspices of healthcare providers? And the answer to that is also no. The government, rightly or wrongly, does not define dentists and dental practices as healthcare providers in their definition. Now, there is some opportunity, potential opportunity for an exemption. And this would be if one or more of the following 3 reasons are true. The first one is by providing this leave, it will so financially cripple the practice that you might cease operation or be able to just barely limp by. Number 2, this person is so critical and so important to your practice that you cannot practice without them. Or number 3, that it would be virtually impossible for you to find a replacement for this person because, again, they are so unique or their skill sets are such that there's no one else out there available, able to work, who can do the job that this person does. So let's tease these apart a little bit. Well, in the first one, how in the world are you really going to claim this financial hardship when the government is reimbursing you 100% for any money you pay out? And also, if you continue to stay in business, how are you going to claim that by providing this leave, it somehow financially crippled you? The second one, you're going to demand that this person come in and work, even though potentially they're sick because they're so critical. And the reality is, if they've worked for you for some period of time, there have bound to have already been times where they went out on vacation, or maybe they were sick for a few days, and you figured out a way to work around it. So it would be a little tough for you to claim that one when you already have a track record of working around this person not being in the office. And the third one, unfortunately right now, there's a whole lot of people who are unemployed, which means then that claiming that there's no one out there would also be a pretty tough sell. It's also important to note that if you were to kind of wave your magic wand and claim that you were exempt from providing this, the exemption only applies to that qualifying reason number 5. None of the others are even open for an exemption. And what about your conscience? You know, you're still in business, you're still practicing, and you're going to look at this employee in the eye and say, oh, I'm sorry, too bad, so sad, I'm exempt. When you otherwise know how important some income is for this person to potentially make rent or buy groceries. It's also important to know that the exemption is not automatic. Again, there is no blanket exemption. And if you get this wrong by somehow claiming you're exempt, the Department of Labor says the burden of proof is on you when they investigate that exemption to see if you truly qualified for it. And then, of course, the question is up to 80 hours of sick leave or $200 a day for family leave, which is completely reimbursed to you, worth it? If you claim the exemption, you are supposed to keep the documentation which is designed to prove your point. You're supposed to keep that for 4 years, which the Department of Labor is saying, we have up to 4 years to come back and investigate this. And I'm not sure that you want that dark cloud hanging over your head for 4 years. And also, please just know, again, it's not a blanket exemption. It's not a one and done thing. It is done on a case-by-case basis anytime an employee comes and is requesting FFCRA leave. Now, buried in the legislation, there is one other little exemption that somehow dentists have tried to latch onto. And know that in leave, anytime there's leave, there is an element of leave which is about job protection. It says you go out on leave, and when you're ready to come back, your job will be there. So buried in the FFCRA, for employers with fewer than 25 employees, it says if someone goes out on leave and when they're ready to return, their job for one reason or another is not there, then you would be exempt from that job protection element. But see, you're not exempt from providing the leave. It's only about the job protection upon this person's return. And even if you want to claim that one, there are rules about you needing to be in contact with this former employee for up to 12 months and figuring out any way to bring them back. So do not think of this as sort of a get out of jail free. I'm just going to do this to have this person not come back. A few footnotes relative to FFCRA. You can't force someone to take other benefits first. They cannot have sick leave and use other benefits, whether it's PTO or vacation, at the same time. They also cannot be on FFCRA, sick leave or family leave, and unemployment at the same time. The family leave and the sick leave under FFCRA can be used concurrently. And when you think about it, the first 2 weeks of the family leave is unpaid. And so it's like sick leave kicks in first, and when sick leave ends after 2 weeks, then the family leave takes over. So that's how these two can be used concurrently. If someone's out on leave and you provide medical insurance, you've got to continue that while they're on leave. You cannot force someone to find their replacement. You can't take adverse action against someone who ends up qualifying for and requests leave. And there is also some posting requirements that you have to have this poster up. There's the website for it. You can also get the website off of our own website to be able to get this printed out and stick it up on the wall in your practice. So the second thing for our little agenda today is the CARES Act. The major provisions of the CARES Act obviously had some grants with it, and then it had loans. And relative to the loans, the one that has the most noise about it is the PPP loan. And a whole lot of this centers around this obsession that people have about loan forgiveness. So in terms of just perspective, first of all, a PPP loan is just a loan. It can be used for anything, although its intention was for you to use it for payroll. The theory behind setting this loan up, calling it a payroll protection program, and putting such favorable terms with it was to try to encourage you to keep people employed so they would not go file for unemployment. They were trying to ensure that the unemployment agencies in all the states were not just completely overrun. The problem is and was that by the time they finally passed the legislation, the train had already left the station and your practices were closed down by your state governments and people were already unemployed. So again, be smart. And I ask you to just consider this question. If it wasn't for loan forgiveness, what would you do? Some people have run out and they're just paying people to just sit home just so they can get loan forgiveness. Well, maybe that's a nice thing for the employees, although they were otherwise maybe on unemployment, but I wouldn't call that the smartest business decision that you can be making. Right now, in terms of businesses, cash is king, not loan forgiveness. Now, relative to forgiveness, here are just some of the basic nuances, and most of you who have PPP loans probably know this. The first, for any monies to be forgiven, it has to be spent during the 8-week window from the date of funding. Number two, at least 75% of those funds must be on payroll, and therefore less than 25% on the other qualifying expenses. It's important to note that this expenditures on expenses and payroll has to be expenses or bills that were incurred during the 8-week period of time and paid during the 8-week period of time. So you don't get to retroactively go back and pay stuff, and you don't get to pay things in advance. There's a wages little threshold that your wages on June 30th or when your 8-week window ends, whichever happens sooner, your wages at that point have to be at least 75% of what they were at the first of the year. And in addition to that, your FTEs on June 30th or at the end of the 8 weeks, whichever first occurs, has to be 100% of what it was at the beginning of the year. Now, there are two things that are happening right now which may help. One is the SBA has already said if you offer reemployment for someone and that person refuses to come back and you document all of that, then you will get some grace with the FTE piece. So there is a little bit of grace that is happening with the FTE part. The other is in the Senate and the House of Representatives currently, both of them have legislation that is designed to relax several aspects of the loan forgiveness. They're talking about even allowing that window to not be 8 weeks and be as much as 12 to 16 weeks. They're also talking about relaxing the 75%. What we're hearing is there's still debate going on, but it potentially will be voted on next week. So just know that this is still a moving target. Lastly, most of you are probably aware, last Friday, the SBA released their loan forgiveness documentation. It's 11 pages long about going for filling out the information for loan forgiveness. When you start going through it, I guarantee you, you're going to get cross-eyed. And here's the thing. Because of these provisions and other sort of fine print details in there, no one is assuring or guaranteeing anyone that there will be, or that you specifically will get loan forgiveness. And what if you've jumped all kinds of hoops and done all kinds of crazy things to achieve loan forgiveness, and then you fill everything out, and because of some fine print or little detail, you don't get it? How are you going to feel at that point about those decisions you did pretty much motivated by simply loan forgiveness? In the whole loan forgiveness thing, you know that there's a differentiation between qualifying payroll expenses and payroll expenses that are to be excluded. Part of the fine print in there, in that even federal payroll taxes, you don't get to count. So it's not just all of your payroll. You have to take your payroll and sort of tease it apart. Now, there is some creativity potentially available to you if you find yourself in a place where you're going, wow, if I could just spend a little bit more of this PPP, maybe it would help or be a good thing for loan forgiveness. Well, here are some little creative ideas. You can give raises, you can pay bonuses, you can pay out any accrued and unused vacation or PTO, and you can see here on the list some of the other potentially creative uses for PPP funds, which would qualify under the guidelines of payroll expense and potentially forgivable expenses. Obviously, you got to talk to your accountant, financial planner. They're your best resource. One of the other major provisions of the CARES Act was the whole unemployment piece, which created this massive freak out. So let's tease unemployment apart for just a little bit. Unemployment, by its very nature, is designed to partially replace lost wages. Every state has their own formulas, and every state goes through their own calculations. In general, regardless of the state, a person ends up getting unemployment equal to about half of what they were otherwise earning. Each state also, though, has a cap where regardless of what the calculation is, they're not going to go above the cap. Here's a list of all the states, and you can see Texas kind of lands about in the middle. The low is about 275, the high is about 700, and Texas, the max you can get is $521 and for a maximum of 26 weeks. Typically applying takes 1 to 2 weeks. There's a waiting period, and then there's 1 to 3 weeks of processing time. Again, the normal length is about 26. Because of what's been built into the CARES Act, they extended that max for people by 13 weeks. Please understand that unemployment benefits taxable. That's something a lot of people mistakenly are not aware of. And the part that became the most sort of controversial was the $600 little kicker that got put in, and it was designed to make people whole because, again, unemployment benefits only equal about half of what you were otherwise earning. You are eligible for the $600 if your unemployment in a given week is at least $1. And so, of course, then the question becomes, well, how does it look for someone to potentially work part-time, still get paid, still maybe qualify for unemployment, and still get the $600? Well, here's an example for Texas. Let's say we have an employee who works 40 hours a week and gets paid $25 an hour. So this person makes $1,000 a week. State of Texas would do the calculation, come up with about half for unemployment, which is $500. Remember, the state has a cap of $521. So this person would get what the calculation is, and they would get $500. Then the state's going to add the $600, and now this person is getting $1,100 versus $1,000. This is what creates kind of the anomaly, because a lot of employees are saying, hey, I'll just stay on unemployment because I make more money on unemployment than I make when I'm working. And it is creating some challenges. Again, you can look at, well, what if this person did some work for me and I worked to help them on the unemployment side also? Well, you see in Texas, this person could work 19 hours. They would earn $475. Unemployment's going to subtract that $475 from the $500. So their unemployment for that week is $25. But you've paid them $475, which means they still get their $500. They still get the $600 on top of that. And so they end up with the $1,100, and you got 19 hours worth of work out of this employee. So potentially it's a win-win. And as most of you know, this unemployment anomaly is still going to exist until July 31st. So we've still got about 2 months, a little over 2 months of this unemployment anomaly. So we're going to change now, and let's talk about reemployment. Reemployment begins with you doing an analysis of staffing levels. Now, given that you're in Texas and you've already been able to open, maybe you opened phased, and maybe you're still in some phases in opening. And all that means you look at staffing levels and what is needed for these various phases as I reopen. Who are we going to potentially reinstate, and when are we going to reinstate them? Clearly, staffing levels should correspond to revenue, not to loan forgiveness. And as was talked about with both Rick as well as Michelle and Maria, is this whole idea of new normals and how much this is going to cause or lead to a restructuring of lots of aspects. And there may not be the reemploying of as many people, because the reality is a lot of your treatment is going to take longer, both during, before, and after appointments. And this will have some impact on staffing levels. The reality also is, as you look to hire, you'll hire some, maybe now, some later, and maybe some not at all. Now, when you go to do this, you've got to also make smart decisions so that you're not discriminating or somehow violating some of the protected classes that exist. And then, of course, you may have employees who decide not to come back. That's also a reality. When you have an employee saying, I'm not going to come back, or they're refusing or they're reticent about coming back, it is key that you have a conversation with them to really drill down and find out the why. As you drill down, there are a lot of the whys that are pretty cut and dry, pretty black and white. They're not coming back because there's a state or a local mandate. They're not coming back because of the CDC or OSHA related issues. Those ones are pretty black and white. If to that list, every single answer is a no, then your options are you can leave this person furloughed and they would continue to get unemployment. you can put this person on an unpaid leave, and they would most likely lose unemployment. And you could also take this as a voluntary resignation if there are not any other, in a sense, mitigating circumstances in that. And as a voluntary resignation, the person will lose their unemployment. Remember, again, with unemployment, you can decide to play with this a little bit. Otherwise, if someone goes to say, no, I'm going to stay on unemployment because I'm making more money on unemployment than you're paying me when I work for you, just know that they are rolling the dice, because unemployment takes a pretty hard line to say, if you are offered work, you are able to work, and especially if that reinstatement opportunity is with the person who you worked for before and you are refusing to go back to work, that becomes a risk the employee takes in losing unemployment at that point. If the answer to any of those questions was a yes, it's related to COVID-19, it truly is related to some state or local mandate, well, then you've got to proceed with caution. Your basic options are, again, you can leave the person furloughed, you can reinstate them, but if it meets the FFCRA leave requirements or qualifications, this person would almost immediately then just go out on FFCRA leave, because a person cannot get both unemployment and FFCRA leave at the same time. Then in this case, FFCRA prevails, and that's the one that they would move forward with. Once whatever the reason is that was COVID-19 related goes away, the employee is expected to come back to work. If the reason goes away and or the employee exhausts all of their leave, again, they're expected to come back to work. They can be put on an unpaid leave if they choose not to, or that can constitute a voluntary resignation. There is also in all of this, of course, a lot of gray area, and that's where you'd want to enlist the help of some HR professionals to navigate through what these gray areas mean, and to the degree you may have to do some accommodation for it. The next piece about reopening is if you can't get all the people coming back that you need, you may have to do some hiring. And just know that the very first thing you always want to focus on in hiring is attitude and fit first and foremost. And secondly is experience and skills, because those things can be taught. So our last agenda item is making sense of employment compliance. And it's like, okay, well, first thing is, what is it? It's one of the 4 compliance challenges that by owning and running a dental practice, you've got to deal with. You've got your clinical charting and record keeping and compliance elements there. You've got Osha, you've got HIPAA, and you've got employment compliance. As it relates specifically to employment compliance, all it takes is 1 employee. And by that, I mean, all it takes is 1 employee, and you have to follow about 95% of all the rules that are out there. A lot of people think that, well, I only have 6 or 8 or 7 or 11 employees. I'm truly a small employer, and I don't have to follow these rules and laws that the big companies do. Untrue. The moment you have 1 employee, you've got to follow about 95% of all the rules and the laws that are out there. And second meaning to this, all it takes is 1 employee to get mad or disgruntled with you, and you can find yourself on the wrong end of a labor board complaint or some type of labor-related lawsuit. To make employment compliance even a little trickier, there are federal rules and laws, and then there's state rules and laws. And here's just a few tidbits out of Texas where the federal law and the state laws deviate. So you not only have to then know what they are, but you have to then know which one you're supposed to follow. And you have to follow whichever one is considered the most stringent. And so whichever law most favors the employee, that's one you have to follow. And lastly, the rules and laws are always changing. And one of the latest big changes that has landed in your lap is all of the FFCRA and unemployment stuff that most all of you are dealing with and facing right now. So the world of employment compliance is made up of a wage and hour component, and this is where making sure that the T's are being crossed and the I's are being dotted relative to compensation and pay and overtime and continuing education and so on. There's also elements about discrimination and harassment. Lots of laws in place today that are all about protecting people in the workplace from discrimination and harassment. They actually create what is called protected classes. These are groups of individuals that have protections in the workplace, and as an employer, you have to be mindful of this and work with it. There's also working with people with disabilities and making sure that you're handling those situations correctly. And of course, then there's the whole game of termination and ending employment. And I know some of you are going, wait a minute, I'm in Texas. And Texas is an at-will state, right? And therefore, I can just terminate anyone anytime I want, with or without notice and with or without cause, and have no problems, right? Wrong. Because today, the reality is you can't fire anyone if it's a violation of protected classes, discrimination, the public interest, or a right against retaliation. All of those things now come before at will. At will does not rule the roost anymore. And so it's not something out there that's just going to save you. In terms of compliance risk, today's dentist is actually statistically more likely to be sued for a labor-related issue than malpractice. And part of that's evidenced by the premiums for malpractice insurance are less than the premiums for labor-related insurance. The average out-of-court settlement is averaging 25 grand. That means no going to court, no anything, just some nasty letters back and forth and negotiating, 25,000. That's the average that's happening in dentistry. And why? Well, it's really just apathy and assumptions and myths. And the question is it really worth the gamble? I would guess that for most of you, your dental practice represents your biggest asset. And so this whole idea of human resources and employment compliance does really represent a form of asset protection. For any of this stuff that I've been talking about to not happen to you, then you've got to gain some awareness. You've got to have a commitment to do something about it. And then you actually have to take some action. Examples of taking some action are making sure that you truly have an up-to-date and comprehensive policy manual that lays out the rules and the expectation and complies with all the federal and state rules and laws. The beauty of a really great policy manual is that it reduces your world and your answer, really any question that comes up, to a sentence that has 5 words. You just simply say, go look in the manual. You know the answer's there. If you have a great manual, you know the answer is correct. And by doing it that way, you're being consistent. Job descriptions are another key element in the employment compliance game. And it provides lots of wonderful benefits. Also, good documentation. Just like it's required for your clinical record keeping and your charting, it is also necessary and critical in the HR side of things. For our clients, we've got a list of all the forms. They can either download them, they can either print them out to ensure that they've got great documentation very, very simply and easily. It's also important to make sure that you are staying up to date and current. The shifts and changes in federal and state laws as applicable. There are changes that affect just the dental industry and would affect your practice based on the number of employees that you have. In our case, for our clients, we provide electronic notification. We keep everything up to date and current. So you could say in a large way, we do the heavy lifting or the grunt work of keeping everything up to date and current. And then we're available for ongoing telephone support and guidance through any issue that comes up. There are a lot of great benefits of taking action: prevention, protection, lowering employee-related stress, and the beauty of peace of mind. So in summary, your HR action plan: don't rush, be smart, focus on success, and get your HR house in order. So if you have a policy manual now, make sure it's up to date. Potentially get it reviewed. One of the services that we provide is a review of policy manuals, so that we'll give you a report about what's good, what's bad, what's out of bounds, what's illegal, what's missing. If you don't have a policy manual, by all means, get one. Get one that's dental specific, based on the number of employees that you have, and truly personalized for your practice, and it can grow with your practice. As I mentioned, get your job descriptions up to date and make sure they truly list the essential functions and are ADA compliant. Tighten up your record keeping, and then establish some type of relationship with a trusted and reliable HR source. So I'll kick it back now to Kay and to Rick for questions.
No, we have a few. I know you're going to have to probably do a lot of them by email, because I know we're running late. Just know that all the questions will be answered. I think the biggest one that I see on here is that if they have an employee that doesn't want to come back to work, and we have PPEs and need to work, what can we do? We can't get through the Texas workforce, and they won't let us know.
Well, if you have the PPEs, and if you are covering all your bases from a TDA and a CDC and an OSHA standpoint, then what you've done is you've taken away the rationale or reason for someone to come back by saying it's not safe. So then it goes to, well, what is the real reason that they're saying they can't come back? If it rises to the level of being a valid COVID-19 reason, like I have no childcare because childcare facilities are closed, or my doctor says I can't come in because I have a lung condition and I have to still wait, well, at that point, your options are leave the person laid off or furloughed, or reinstate them and they go on FFCRA leave. If the reason they're giving is not a valid COVID-19 reason, at least from the standpoint of human resources and employment compliance, then you could, like I said earlier, go down the path of a voluntary resignation, or you can go down the path of unpaid leave.
Oh, and I will say this, there's more questions, like one of them, and Roy, why don't you go ahead? But let me just say this real fast. Ben Erickson is a partner of Binco, so if you definitely need a manual. If you don't have one, it's super important. Like that was a great question. They couldn't get through the Texas workforce. That's why you need an HR manual. You pick up the phone and you call Tim, and Tim takes care of your question. So, please contact your local Binco rep, and we will definitely make sure that we put you in touch with them so that you can get a manual for your participants. Believe me, the cost is very reasonable, and you definitely want to make sure that you have it. The last question was, can they give the PPP as a bonus to their team?
Yes, sure.
So that's hopefully, and Tim, we'll send you the other questions. Great job, great information. I definitely have heard that more than once about the employees not wanting to come back. So I think that you covered that really well. Again, and if they want a manual, how long does it take to put a manual together?
Well, it's more a matter of how accessible the doctor and or the office is, but it can be as short as 10 days.
Fantastic. So guys, please make sure you reach out to your Binco rep and let them get you a manual. I think it's the best thing that you can do, especially right now. Thank you very much, Tim. With that being said, I'm super excited to introduce our next speaker, because he's going to tell you how we're supposed to get all this stuff paid for. I mean, I had said on some webinars for Roy, we've actually spoke together too. Is absolutely amazing. When my offices call me and say, hey, I'm not sure, and I'm not sure, I pick up the phone and call Roy. There's no one that I trust more with the questions about the insurance and how we can get paid and what are we doing right than Roy. So Roy, I know we're running late, so I'm gonna go ahead and turn it over to you. Thank you so much for being here.
Pleasure to be here. Okay, thank you for the invitation. Thank you for letting me listen to some of the comments. My head's kind of spinning. And I'm thinking, I have expertise in a particular area, and I'm seeing all the other things that we need to be aware of. Certainly, it's a whole new world. I don't know if it's brave or scary, probably scary more than anything else. My area of expertise is documentation, billing, and coding, and we have a few minutes to talk tonight, and I want to focus it specifically toward getting paid for some of the changes we're going to have to implement in our practice. And I've got good news and I've got bad news. It depends on your status of participation with the insurance plans, whether or not you're going to be able to recoup some of the expenses that we're obviously going to have to expend to provide the appropriate PPE going forward. You know, I've looked at certain numbers, and the amount that I'm seeing that is being paid to be able to provide all those preventive services is astronomical. And, you know, is it going to be the standard going forward? I don't know. My crystal ball doesn't work very well, but I can tell you in the state of the situation today and what insurance companies are doing and are providing, there is limited support. First and foremost, I recommend that you look at the expense as it relates to providing care today, and certainly that's going to be difficult to do. It's going to take some time to be able to figure out, okay, how much are we now expending to be able to provide the care in Texas that is required under the state mandate? And, you know, that's going to be hard to determine. There are a lot of moving parts, moving pieces. Certainly you're not going to be able to see as many patients as you did. So as far as the ability to be able to generate the income, it's going to be reduced. So there again, it's one of those things that it's uncharted water. We don't really know. So I encourage you over the next few weeks, months, look at what those expenses are. Certainly at this point, you need to kind of estimate from what you've been what you've had to buy to be able to provide the appropriate PPEs. And, you know, the question is, do we charge a PPE fee? How do we handle that? How do we handle the increase? And, you know, I can't really tell you at this point. What I can tell you is I've seen two different ways of doing that. I've seen practices who have adjusted their fees accordingly to raise their fees for their services to take into consideration that increased amount that they're having to expend to provide the necessary changes in the practice to accommodate the COVID virus and the way the patients are now being seen. And I've also seen practices that have added a PPE fee per visit. I can tell you a lot will depend on whether you're in network or out of network, and this may be one of those opportunities you have to be able to review the fact that you're participating with that plan and looking at your overhead and your expenses to figure out if you can actually afford to be in network with those plans now. And the reason being is that most of the plans, most of the insurance companies that I have been in contact with and had people that I know in the industry with what the insurances are doing, if you're in network, most plans do not provide a benefit for the PPE. And I've seen it all over the boards. I've seen some Delta of New Jersey, Delta of Connecticut are paying $10 per patient interaction. I have seen Delta of Tennessee giving grants for $1,000 to be able to buy PPE. I've seen it all over the board. And I can't tell you at this point in Texas what you can expect, because it is a new and different world. it's kind of like the wild, wild west. I cannot give you guidance. I can give you guidance as to how it can be billed. And because the American Dental Association has actually provided that guidance from the American Dental Association, if you're charging a PPE fee, they recommend that you actually code that as a 1999, a non-specified preventive code, and affix a fee to that. And ultimately, if you do that, it's an all or nothing. That meaning that if you have a PPE fee, then you charge it to all your patients regardless of whether they have insurance or not. There again, you have to be concerned about doing it appropriately. If you do it for one group of patients as opposed to charging another group of patients, the argument could be made that you are actually discriminating against one group against another. So if you have decided you're going to charge a PPE fee, my recommendation is to charge it to everybody and let the chips fall where they may. So if you're in network with certain plans and that plan comes back with, we're not going to pay for the PPE fee, we're going to disallow that. Disallow means that they're not going to pay for it and you can't charge the patient for that. So if you're in network, you've signed the contract, you're obligated to adhere to that determination by the insurance carrier. If your insurance carrier denies it and they don't disallow it, it means if they deny it, you can then bill the patient for the amount that's not covered. And of course, if you're out of network, it really doesn't make any difference. You can bill the patient and expect the patient to pay that PPE fee. The kicker is, how much is that fee? How much does it really cost to be able to increase the amount of protection that you're providing for your patients? How do you determine that amount, and how do you affix that to a claim? I can't tell you. I don't know that anybody can until you actually look at that and determine what that cost is per patient. I can tell you that it's substantial. I can tell you that it also limits the number of patients you can see, the amount of patients you can see per hour in hygiene or in the regular restorative area. It's going to be constricted. But back to the billing part, the American Dental Association has suggested you use a D1999 code, and I'm going to give you a little tip. If you send that in, the insurance company, when they get that 1999, they will not automatically adjudicate that, which means it will not be processed. It will kick that claim out of processing, and somebody's going to have to review that and follow up. So if you are billing for that PPE fee and you're using the American Dental Association's suggested coding, D199, I recommend that you put all your normal billing, all your regular codes. So if a patient's coming in for a basic cleaning, you do an evaluation, you do the prophy, you do necessary x-rays, all that go on the claim form and be sent to the insurance carrier. And if you're charging a PPE fee, then go ahead and put the 1999 on a separate claim form and send it in on the date you saw the patient. The reason why I recommend doing that, if you put it all in the same claim, the insurance company is not going to process that claim until they get further information about the D1999. It's going to delay the reimbursement. So in order to help streamline the process, go ahead and put the regular services, not the PPE fee, on a regular claim form. Go ahead and send it into the insurance company as a separate claim, and then attach the D1999 fee to that separate claim and send it in and determine whether or not the insurance is going to pay for it. And like I said, I can't tell you whether they're going to pay for it. I can't tell you whether they're not going to pay for it, but that would be the most appropriate way to be able to submit the claim to the insurance carrier. And like I said, I don't know what the insurance company is going to allow. Like I said, some are actually paying a per visit fee, and how you use, post that to your patient visit, there again, that would be a separate code, probably a proprietary code you use in your practice that identifies that fee, and it's going to be a wash. So if you're in network, they pay $10, you receive the $10, you post the $10, that's not going to be billable to the patient separately. So there again, is there an accounting issue you need to be aware of? Yes, there absolutely is. Is that going to change? Maybe. We don't know moving forward. As far as the coding goes, a separate coding for the PPE, the way the coding in the dental world proceeds, it would be very unlikely that the Code Maintenance Committee from the American Dental Association would adopt a code midterm, meaning that the Code Maintenance Committee meets once a year in March. We met this year. In fact, that was the last meeting that I attended. It was in Chicago. They dealt with the list of codes that were submitted to the Code Committee for evaluation. They were either adopted or voted down, and those will become effective January 1st of 2021. They do that once a year, and since this whole pandemic happened and the whole PPE issue happened after that coding committee meeting, I think it's going to be very unlikely that you're going to see any codes specific in dental for those PPE charges until 2022. So is there going to be any quick fix in the future that we can have a specific code dealing with that specific PPE code? Will there be one adopted before that? I think it's unlikely. The American Dental Association may take action and add that. From my understanding, they don't have that ability, that flexibility to be able to do that. So don't look for that to occur anytime soon. So there again, the PPE issue is one that we're all concerned with, one that we have to deal with. Is it one that I can give you any concrete information on? I can't. It's being dealt with per plan, per insurance carrier, and some of them are actually allowing payment. However, the ones that I have seen who are making payments to dentists per visits for the extra PPE, they've limited that reimbursement to a very short period. Now, whether or not they're going to increase that, move it out further, target moving. Don't know if that's going to happen. Don't know if they're going to move it out. Don't know what the changes are going to be. But I can tell you at this point, that's the way that I recommend that you handle that. Kay, do you have any questions about the PPE fee, the billing for? We can handle those now.
Hold on one second. Let me just get this on. So, we did have a question I thought was kind of interesting. It says, let's see, where is it? Hold on. Is it okay to bill the PPE fees when we reuse the gloves and masks? So if the office is not changing them out between all the patients, can they actually reuse that? Can they use that code?
Sure. I would suggest even if you're reusing them, if the overhead that is being expended, of course, it would be reduced if you're reusing them. It wouldn't be as high a fee as if you use new every time. But I would factor in the increased amount, even if you're recycling them, if you're reusing them appropriately, that would reduce the overall fee, but there would probably be an increased fee. So your PPE fee would be based on, for your office, your practice, and how you're rotating that fee, how it represents that per patient visit. So it would vary per office, how you're actually using that PPE.
And then the other thing too is that, and Roy, if the patient is seeing the doctor and the hygienist, like if they're getting treatment done in the doctor's room and they're seeing the hygienist, would that be a double charge?
Well, actually, that's probably a quadruple charge. Ultimately, you don't charge 4 times, but it's a 1 charge per patient per visit. So the example you use, so if the doctor is fully garbed with all the PPE in the treatment room, that doctor leaves the treatment room, goes to the hygiene room. They're going to have to degarb. They're going to have to regarb going into the hygiene room. They leave the hygiene room, they degarb again, they go back into the treatment room and regarb. You know, that's not just one additional. You're going to have to do that each time you're actually disrobing and taking all of it off and putting it back on again. So there again, it's a moving target. The overhead increase based on what you're actually doing in your practice, and you're going to have to look at that and determine what's most effective. You know, that practice that used to, the doctor in perhaps in the middle of endodontic treatment, when there's a radiograph being taken, it would be a great time for them to leave the endodontic treatment room to go to hygiene to check hygiene. That may not be the best use of the time and PPE that they have now. So like I said, it's one of those things you can't say, well, this is the charge, because every practice is going to be different in the way you operate, and you have to think a little bit about how you do it most effectively so that you don't, well, number one, waste PPE, because that's, you know, trying to find the mask that you need and the gowns that you need. You know, is that going to be, you know, is it effective to rotate those when you leave the room and come back again, or is it more effective to see fewer patients and not have to do that? So there again, the way we practice and the way we practiced before this happened is very different, and the numbers are going to change very drastically. Great question.
And the other question was that, you know, if they're doing like a crown seat and it's a no charge, although I know that, you know, it's going to be a day of liability, right? But apparently if they're doing it as a no charge visit, can they still charge the PPE if it's a no charge visit? And the reason they're asking this also is they have a lot of ortho and they see their ortho patients every 2 weeks.
Absolutely. If you're going to implement it, it should be uniform, and it should be for each patient encounter. So if it's no charge or if it's charged, the PPE part is going to be the same. You're going to have to put on the same garb you would for a ortho check as you would for the whole ortho placement. Or if you're doing a seat crown, you're going to have to do the same type of room setup. You're going to have to do the same kind of barrier system as if you were doing the crown preparation. So, well, a little bit different. There's an aerosol involved, but very similar.
Fantastic. Okay, you can keep going.
Okay, so we talked about the PPE. Let's talk a little bit about, there's a huge push in dentistry about teledentistry, and it's a two-edged sword. Do I recommend that you implement a type of telemedicine, teledentistry in your practice? The answer is absolutely yes. However, in Texas, there's a limitation to what you can do using video conferencing, either synonymous as the person is in the chair, or synchronous or asynchronous, sorry. There are limits to what you can do. In Texas, you cannot do an evaluation per the Dental Practice Act unless the patient and the doctor are in the same room and the doctor is hands-on with the patient. I'll say that again. In Texas, your Dental Practice Act limits the evaluation to a face-to-face interaction. So teledentistry, telemedicine it's an amazing way to be able to interact with your patient, to be able to get some information. And I do recommend that your practice do implement telemedicine. Unfortunately, the limitation in the state does not allow you to do evaluations. So let me suggest to you a way that you might be able to implement it and make it work for you. Especially in today's world, when you're trying to limit the interaction, the direct interaction with the patient face-to-face in the practice, this is a way of doing a lot of triage prior to having the patient come in the practice. So number one, you need to be aware that there are HIPAA considerations, and even though they've lowered those restrictions, and in fact, they say they will not hold doctors responsible for HIPAA type violations during this pandemic. meaning that you can have an interaction with your patient that does have restricted information conveyed back and forth by means today that would not meet the regular standard, the HIPAA standard, meaning that you can do a FaceTime, you can do a Zoom, you can do certain type of interactions with your patients that don't meet the standard, the HIPAA standard, but the standards have been decreased so that you can actually conduct those now and not be held responsible for it. Which means that a patient who calls in and says, you know, I want to make a new appointment, I need my teeth cleaned. And in the past, more than likely, there would have been a conversation at the front desk. There again, I would not guarantee that they would get a cleaning, hopefully, because you don't know how that patient's going to present. But in today's world, you want to minimize the amount of time that patient is in the practice. You want to set them up, tee them up for an appropriate triage to get them treated appropriately. So there are ways to use video conferencing to get a little bit deeper into the assessment process so that that patient, you can have a discussion with the patient about their situation. More than likely, when patients present with situations as they have, and you know, you can get a hygienist involved. Hygienist can have an interaction with the patient, have the patient bring that camera very close to the mouth, and the hygienist can look, and you know, you can't diagnose and you can't evaluate at that point, but you can get certain ideas about the patient's current situation and about how they need to be treated. And the verbiage would not be, you have periodontal disease, because you can't diagnose, but you could say, you know, it appears that there's some issues with your teeth and your tissues that may need more than just a cleaning. You know, sometimes when the doctor sees situations like this, the recommendation is scaling and root planing, and that may be the issue. So rather than suggesting to you that a cleaning would be an appropriate treatment for you, I would suggest to you that you come in, we do an evaluation and determine what would be the appropriate treatment. So that patient is set up, they're teed up for something different, and a way to be able to do this, I would suggest you use, rather than taking into consideration today's reduced restrictions and the lowered HIPAA requirements, I would go ahead and set it up now so that it would be, it would meet HIPAA requirements moving forward. So there are some patient communication platforms that now have, that we deal with every day, that now have teledentistry components with them. Solution Reach is one, Revenue Well is one. There's one that is one that's been used in medicine for a number of years. It's Doxy, DOXY.me, that meet the requirements, the HIPAA requirements, so that if you go ahead and put those in place and start using them today, it's a way to be able to make sure that you're going to be compliant today and tomorrow. But I would use the teledentistry, the telemedicine, as a way to minimize the amount of time that the patient spends at that front desk answering questions. You can do your health history through that. You can go ahead and do your informed consents by those video chats. And it's a way so that when that patient walks in the front door, you're able to escort them directly to the treatment room and not have them at the front desk, and be able to free that up and not have people who are congregating there. So I encourage you to use that. As far as the billing codes for the teledentistry, it's a 9995 for synchronous. That's when a patient is, you're having a direct interaction, and there's asynchronous, which is 9996. I may have had those backwards, sorry. And if you're doing an evaluation or a screening, that would be a 190 or 191. Now, the insurance companies actually have indicated that if you do a 140 at that using telemedicine, teledentistry, they would pay for it. But here again, I want to tell you that in Texas, you cannot do an evaluation. So do not bill for an evaluation. You can bill for a screening or assessment. The insurance is not going to pay for that, but it will give you a way to be able to track what you've actually done. And then the teledentistry, the 9995, the 9996, you can go ahead and track it that way, so that you're actually using that to set the patient up, getting them ready to be able to be seen more directly. Like I said, if you're having patients who have to wait, if you're having people waiting at the front desk, I would use that video conferencing as a way to circumvent that, so that they don't have to stop at that front desk. When they're waiting outside and you text them and say, we're ready for you, the patient is escorted directly from the front door into the treatment room, and everything else is taken care of, and you can do that via video, and it's a very effective way to do that. As far as the visits afterward, follow-up visits, as far as post surgical follow-ups, I would do it that way, face-to-face, because it's more personable. You know, even though we're having to be less personable now with masks on and with all the other things, patients can't even see what you look like. However, if you use the video conferencing, you can actually not have any of that off, so they can actually see what you look like. They can see the smile on your face. You can develop that relationship that way without having to walk into the room all garbed up, and they have no idea if the person who is seeing them is the actual doctor who is in the practice, who owns the practice. So just suggestions that way. You know, we're 10 minutes till the top of the hour. We have any other questions? I know these people are worn slap out. I want to give them an opportunity to be able to relax if they can.
Well, so, you know, I guess the biggest one, though, is that now, so if they're on PPOs and they're already under an agreement, like they have a contract, so do you recommend that they go back and renegotiate their contract, or do you think, now I've heard differently. I've heard some people say, no, don't charge the charge, go ahead and increase your fees. Do you recommend both? What do you think they should do? I mean, and also making sure that they stay in their guidelines of their contract. Yeah,
I would do one or the other. I would either implement a PPE fee, or I would raise the fees altogether. And you're exactly right. The people who are in contract with the insurance company, they will more than likely disallow it, which means they cannot charge the patient for the difference. Being able to negotiate that with the insurance carrier, I doubt that would be possible. Insurance carriers will negotiate services that they do cover, but as far as bringing services in that I'm going to back up a little bit. Those plans are developed, and the employers buy those plans for their employees, and it's very, very stringent. It's laid out very specifically about what's covered. For an insurance plan to be changed midterm, that's very unlikely that they can do that, because the employer has paid X amount for the plan, and now the plan is going to have to pay an increased amount, and the employers, the amount that they're paying for their covered employee, they will not change that fee. They can't change that in midterm. So the chances of the insurance plan going, oh, okay, we're going to pay more for this. Oh, by the way, we're only getting paid the same amount from the employer. It would be unlikely that would ever happen. So that would be something that could be renegotiated when that employer had the opportunity to be able to buy another plan or to re-enlist in a plan.
Do you think, however, like, how is it that Delta can do so many different things for so many different states and not follow one guideline? I mean, Delta just seems like it's all over the place.
Well, Delta, if it is a state plan, is regulated by state law. So all state laws are different, and that's the reason why there's no uniform plan all over the United States. Texas has a different insurance commissioner, have different rules and regulations than Michigan or Kentucky. And that's the reason why everything's different, just like the coordination of benefits. You would think that everybody would have the same regulations, the same rules as far as coordination of benefits. It's all over. So unfortunately, as long as you have different states who are in charge of the insurance products that are sold in that state, you're going to have differences in those products, and they're not the same. And the scary part is, different plans can develop and provide different coverages. So Delta Dental in Texas can have 5 different plans and cover 5 different things. you know, that's the reason why I have no hair. You pull your hair out trying to figure out what in the heck's going on.
And so then I have another question. So are you saying that, like, if they see a patient for an extraction or a root canal, can they follow up doing a Zoom call with the patient, or does the patient have to come in for a follow-up?
You can do a Zoom call. If it's, you know, if it's a follow-up visit, there again, you have to meet standard of care. So if it's just if it's a regular visit, the patient isn't having any kind of complications, any problems, can you do that through a video conference? You absolutely can. If the standard of care would need to be met by the patient actually sitting in the chair and the doctor pulling the cheek back and looking at that patient, then the patient would need to come in. So the doctor is going to have to use their judgment to make sure they meet the standard of care. If they can see and they can hear what they need to be able to make a judgment and a recommendation, by all means, go ahead and do that. But if they can't, if they need more information, if they need hands-on, then the patient has to come back again. I'm sorry, I can't give you a cut and dried answer, but ultimately the doctor is responsible for meeting the standard of care. So that would be what another doctor in the similar situation would consider a reasonable way of dealing with a patient. That is considered meeting the standard of care.
Okay, and then would you go over the code one more time, the code, and do you also have an estimate charge that they should be charging the patients?
So as far as the PPE fee, I encourage you to look at the additional expense that you have now had to endure to provide the extra PPE. Look at the average number of patients you see per day and divide that per patient fee, or the total fee, by the number of patients you see. And that will give you a working number. Unfortunately, there's not enough information out there to be able to determine what's considered normal fee. And that's a work in progress. There are a lot of people who are working to see, you know, what that is actually going to be. And, you know, it's a moving target. So at this point, I can't give you what's considered a normal fee. I've seen anything from $100 per visit to $150 per visit.
Oh my gosh, really?
Yeah, so it's all over the board.
Wow. And I mean, are insurances paying that?
No.
Oh, okay, because I had heard just the opposite. So I'm like, wow. And then, you know, I really want to end with this.
Yeah.
If you're a doctor on the phone, on this webinar, I will say this. No one knows better than Dr. Shelburne about, you know, keeping out of prison, and you need to know what your team is doing in the front. And I mean, I think that's a great way to close this. And I definitely think, Roy, that you actually do in-office coaching for this. So I hope that you definitely will give them your email address or whatever you want to reach out to them. But this is super important, and you know, don't just let your front desk handle it. You really and truly need to make sure that you stay in touch with them. So I think, you want to end with that?
Yeah, that's my contact information there on the screen. Ultimately, doctors, you are responsible for everything that happens in your office. So if your team does not meet the standard in terms of the protection of the patients, if they're not interacting appropriately, if they're not disclosing the correct information, if they are having those video conferences with your patients and not meeting the standard of care, even though you're not the person who's doing it, they are doing it on your behalf, and ultimately you will be responsible for meeting the standard. You can't say I didn't know. You can't say I didn't do it. You can't say that I didn't tell them to do that. They are acting on your behalf. And the expectation is they have the training and expertise to be able to do it correctly. It's your responsibility, if you don't do it directly, to provide that person with the correct training and expertise and supportive information, education, training that's necessary to meet the standard of care. They can't say, I didn't know. It will not, there's no such thing as I didn't know. Ultimately, you will be responsible for the HR. We heard all about the PPE. We heard about the testing. All that falls on your shoulders. I'm sorry to say that. But,
yeah, I mean, I've even heard like some people go, oh, you can't just charge some patients. You have to charge everyone the same. You really do need to know what's going on in your front desk. I mean, you know, and I mean, it's just right now, especially at this time, don't just let your front desk handle it. Go, oh, well, whatever they decide they're going to do.
Yes.
But, you know, really, I think reaching out to you, Roy, and really getting some good information and guidelines on that, because every single state is different. And like you said, every insurance company is doing their own thing. Okay, I'm sorry.
It's never been more important to be aware of the pitfalls, because there are going to be vultures out there who, there'll be attorneys who say, were you injured? Did you contract COVID at your dental practice? I can tell you that ultimately there will be people out there who will point their fingers at the dental profession and say, you didn't do what you're supposed to. And there's no way that you could say, well, I'm sorry, I didn't know this was new to me. I had no idea I needed to do that. Ultimately, you will be responsible for it. You know, do I want to scare you? Yes, but I also want to encourage you. You only need to be scared if you choose not to do it appropriately. Thank you, Binco, for putting these together to give the people the information they need to either learn what they need to do or know where they can seek and get the information that they need to be compliant.
Well, you know, Roy, I will tell you, I appreciate your time. And again, I want to say all of these speakers have volunteered their time to come on. I know Roy's going to be doing some workshops for us, and I'll let you know when those dates are set. So if you have someone in your office that you really want trained on this to make sure it's right, there should be a 7-step compliance, if I'm not mistaken, that every office should have. If you don't have it, you could be, again, liable. And again, you would be put in prison. And I guess they're putting team members in prison now too, but you just don't want to go there. So just make sure you have the right protocols and systems. Keith, you want to come on real fast? And I don't know, Rick, if you can turn your camera on. I don't know, Keith, can you turn your camera on or no? There you go. I just want to say thank you to you and Rick for putting this on for Texas. I think this is really important, and I think that there's going to be a lot of good information that comes out of this for your Texas team. So we really appreciate this. And then all the speakers, thank you very, very much for this afternoon. Anything else you want to say, Keith? I didn't know if you had anything to say.
I just wanted to thank everyone for putting this together, and thanks for all the volunteer speakers. Kay, you're great as usual, and Rick, his microphone's not working, but I know he'd say the same, so thank you.
You're welcome. Everybody have a good night. Again, it takes about 30 days to receive your CEs. They will be coming in, and we'll keep you posted on Roy's upcoming workshops. Everyone have a great evening. Thank you very, very much.
Thank you.